Beginning with the next chapter of general pathology, and that is genetics. Now, well, you have been studying genetics way back since your school days, but definitely it's something that's been troubling you also since your school days. I'm going to teach you genetics divided into certain segments. First, we'll start with all our basics, our introduction portion. Then we'll go to all the different Mendelian, non-Mendelian, chromosomal, and all the diseases that you have to know. And in the end, we are going to cover all the diagnostic modalities that you need to know for the exam. I'll wrap up this entire session with you knowing certain updates which are a must now in the field of genetics. Well, having said that, let's begin, and trust me, the way we are going to study genetics, I can guarantee that you will be able to solve all the questions at the end of this session. Let's start right away. So first we are going to start with the introductory portion, which asks you as a previous year question, what are the number of genes that are present? So I'll tell you the answer that is written in most of the textbooks, and that is 20,000 plus. But when I say plus, there's obviously no limit. See, genetics and means every day we are discovering new genes out here, right? So now actually there are many articles which are also saying 30,000 and more genes have been identified, but most of the books still mention 25,000. So we'll go with that number. Now, talking about what exactly is a gene made up of, I've drawn a small diagram over here. Every gene has two parts. You can see there is something known as an exon, and then there is an intron, then an exon, then an intron. What is the meaning of these? Please remember, exon has X in it, extrovert. Extrovert is who? Extrovert is a person who talks a lot. So that is the part which is going to be the coding region of the gene. So like I said, exon or extrovert is going to be the coding region. Whereas when I talk about the introns, what does it sound like? Introvert. Introvert means is not going to talk. So that is going to be the non-coding region. So remember, introvert and extrovert. That is how I have learned it. Now, if you ask me who is more in the genome, to your surprise, do you know that introns actually comprise 98.5% of your genome? Majority of your genome happens to be of the non-coding variety, whereas exons are only going to comprise roughly 1.5% of the genome, and mark this as a previous year question. 1.5% of the genome are the exons, only 1.5. Okay, having said that, this was the first, what are the parts of a gene. Now I'm going to tell you where is a gene located. What did I say? Where is a gene located? When I say located, it means location. So basically guys, location means locus. What is locus? Locus is defined as location of a gene. Where is a gene present? On a chromosome. So please remember, where on a chromosome is the gene present. So for example, if I draw this as a chromosome, you will ask me, is the gene present over here? Is it present over here? Which part of the chromosome is it present? So please remember, every chromosome has a short arm, you can see that, and it has a longer arm. It has a short arm and a longer arm. So the short arm is defined as P. You know what is P? P means petite. Petite in English means small. So if P is petite, then the next alphabet becomes Q. So Q becomes the long arm. Repeating, P is the short arm, Q is the long arm. So now I'll give you an example. If you ask me that where is chromosome, or where is the main policeman of our genome present? I hope all of you have gone through the neoplasia chapter. If not, you will be going through it next. And where is the P53 policeman present? It is present on chromosome 17P. So what did you analyze? 17 becomes the name or the number of the chromosome, and P becomes the which arm? P becomes the short arm. Is that information enough? No. If I ask you for your address, and if you only tell me that I stay in house number 2, will I be ever able to reach your house? No. You'll have to tell me house number 2, then your street, then your pin code, your city. You will have to tell me the full house address. Only then would I be able to come to your house, right? So if you just tell me chromosome 17P, I cannot mark that. Actually, it's written as 17P13.1. So it's told you the house number, the street number, the city, the pin code, everything. What is this 17P13.1? Now I'm going to tell you a mnemonic which we are all struggling from, that we don't want to eat but we can't control ourselves, and that is carbs, carbohydrates. Carbs is the mnemonic. Means what? First, you are going to tell me C for the chromosome number. Next, you're going to tell me the A for arm. Which arm is it present on? P arm, Q arm, short, long. After that, what is RBS? So remember the next three numbers that you've got over here. These three numbers are RBS, means this stands for region. This stands for region. The next one stands for band. Next one is band. And the last one is the sub-band. This is referred to as sub-band. So now try to put it in your carbs mnemonic. See, you have something called C for chromosome number, A for arm. What part of that arm? Region number 1, band number 3, and sub-band number 1. So anytime you get something like this in the paper, write carbs in front of it. Chromosome, arm, region, band, sub-band. So if I randomly ask you, what is 3 standing for? So you will say chromosome, arm, region, band. So 3 stands for band. That is how you define a chromosome. Remember the mnemonic carbs, okay? Now coming to the next definition. What do you mean by an allele? Now I think this is a definition you know from your school. When I say one gene, I think everyone has got a point that there is a dominant and a recessive. Like for example, I say that there is something called A gene. Let's take just a random example, A gene. You will say it exists as a capital A and exists as a small a. So can I say 2 forms are there? Can I indirectly say that every gene is going to have 2 forms? Every gene is going to have 2 alternative forms, and these alternative forms are known as alleles. Repeating, alleles are 2 alternative forms. So I am the same person. For example, you are the same person, but one day before the exam you are a different human being, and 1 year before the exam you are a different human being, right? So 1 year before the exam you are a little chilled out, but one day before the exam you're very panicky and hyper and anxious, right? But you're the same person acting differently in different situations. Same way, we're talking about the same gene, but it has 2 different forms that are there. What are those 2 forms known as? Those 2 forms are alleles. One of them is the capital form, one of them is the small form. So the capital form is known as dominant and the small form is known as recessive. Got it? Now, if I'll start making some combinations, let's see if you can pick it up. For example, you have A gene and both of your alleles are capital A, capital A. So every gene has 2 alleles, both of your alleles are capital and capital. Can I say you are a homozygous person? Homozygous means the same 2 alleles are looking same. They are twins, homozygous. Same way if I say small a, you will say both of these are also same. This will also be a homozygous person. Whereas now if I say someone is having 1 capital A, 1 small a, that person will now become a heterozygous person. Remember, yeah, this is making sense. Same alleles are there in the same person, homozygous. Different alleles are there, heterozygous. But tell me one thing. If 2 things, this is a rule that I'm telling you for the entire genetics, whenever 2 things will be there in a particular table, only one will show the expression. Means if you and I are currently in this recorded session, only I am the one who is talking because I have to teach you. So I am the dominating person because I am talking. You are right now the recessive person because you are listening, right? So there will always be one dominating person who will be talking, and there will always be one person who will be listening, and this is the best way to learn. So please remember, if there is a dominating person, if both of them are capital A, ultimately who will express? Only one can express. So if you and I are in a room or in a recorded lesson, we can only and only have one person talking. So right now only I am talking, capital A. On the other hand, so this is the situation that you had, capital A and small a. So till the time capital A is there, till the time I am there, I am the one who's going to talk. So whether I am only over here with myself in this situation or I am with you, but whatever may be the situation, a dominant person in the room means only a dominant person will talk. On the other hand, when you, small little kids, when you are with your friends, then obviously that is the only time when you start your discussion and when you start talking, right? So can I gather from this situation, if I had to make a general rule out here, what did I see? That a dominating person is going to talk in any situation. Means a dominant allele, can you tell me, is it expressing in homozygous condition? Yes, it is expressing in a homozygous condition. Is it expressing in a heterozygous condition also? Exactly. And that is the question that you get. Dominant allele is going to express in homozygous as well as heterozygous condition. On the other hand, when I'm talking about a recessive allele, you kids, when are you expressing? So you obviously in front of me, you will feel a little shy. Although you shouldn't, but you will feel a little scared and you will feel a little shy. But in front of your friends, you will be very, very comfortable, right? So a recessive allele will only manifest with friends, or recessive allele will only express when with similar people, that is in a homozygous condition. So repeating once again, in a easier way to learn, a dominant person will express dominating personality, will talk anywhere. You put him in a homozygous situation, you put him in a heterozygous situation, dominating person will always talk. Whereas a recessive person, a small, a quiet kind of a person, will only talk when he's kept in similar situations, that when he's kept in a homozygous situation. On the other hand, you say, right now, ma'am, you have spoken about only you being the dominating person, only me being the dominating person. What if you keep two dominating people in the same room? What is that situation known as? That is known as codominance. Now let's talk about the next concept, and that is codominance. First, I'll tell you the example for it. Everyone has heard of the famous AB blood group, and also you will be talking about a gene called the HLA gene when you will be going on to the immunology chapter. So let me explain this concept to you with the AB blood group. So first and foremost, let me tell you what are the genes that we have in the blood group system. There's a capital A, there's a capital B, and there's a small o. These are the genes that God has given us. Why did I write capital, small? This means A gene is dominant. That is why I've written it as capital. B gene is also dominant, written as capital. But O gene is written in small, means it is recessive. Now you need to know that if I make a column of what are the genetic composition that a person can have and what is the blood group that the person is going to have because of it, let's see that. So for example, someone is having capital A or a genotype of capital A small o. There are two people I have taken in this situation. A person having capital A, when there is only A gene, obviously the blood group is going to be only A, no other possibility. But over here, there is capital A and small o. There's another person, his genotype, he's got A from the mother and O from the father, right? So there's a capital A, there's a small o. Who will express out of capital and small? Who always expresses? The dominating person always talks. Even in that situation, the blood group will still be A. So whether it is AA or whether it is AO, till the time capital dominating person is there, that person is going to talk. Coming on to the next, BB or BO means if there's a person having genotype BB, B from the mother, B from the father, this means the person is going to have a blood group of B. Blood group is going to be B. On the other hand, if a person is having B and O, capital B, small o, then also B. Till the time you have a dominating person, only dominating will talk. When will a person be O blood group? When both the alleles are OO. Only in that situation will a blood group O scenario arise. So till the time O is not with itself, and that is what I told you in the previous segment, that for a recessive allele to talk, it has to be in a homozygous situation. This means for the O to talk, it has to be in a homozygous situation. Finally, I tell you what is known as if a person has both, if there are two dominating people in the same person. There is A gene also, there is B gene also. There are two superstars in a movie. Both of them will have the best acting. There are two dominating people in the room. Both of them will talk. This is like an integrated session. If you have a pathology teacher and you have a surgery teacher, both of them are going to teach you together in an integrated manner. So the blood group will end up being both the dominating alleles expressing. That is exactly what I am telling you. That is codominance. What is codominance? both the dominant alleles will express. Both the dominant alleles are going to express. I hope everyone is okay with this. Two dominating people, both will talk. Example, blood group AB. So all the AB people in the house, today you got to know you are co-dominant. Another example of this is the HLA gene also. Having discussed this, the next concept that we have to know is what is pseudo-dominance, fake dominance. I'm feeling I'm dominating, but no, someone else is going to come across. So there is some pseudo-fake element that is involved. So let me ask you. For example, everyone must have heard of a very famous disease called hemophilia. What is hemophilia? Hemophilia A, B, it's a bleeding disorder, right? I'm telling you right now, it is an X-linked recessive condition, which means that if there is a capital X and there is a small x, tell me one thing, capital X and small x, whom do you think is going to dominate? The capital person is going to dominate. So tell me, I'm going to write over here, this small x has the disease element. The disease problem, the hemophilia problem is in the small x. But this patient is capital X, small x. Who is the x which is going to talk? The dominating x is going to talk. So do you think this person will show you the disease? Is this female going to show you the disease? No, this female is not going to show you the disease. Why? Because when capital and small is present, even if small has the disease, but right now, every time a capital person is there, a capital person is only going to talk. So ideally, this female is not going to show you the disease. There is no manifestation of the disease. But why? Because the dominating person is fit and fine. However, if I say this small tiny little disease one starts showing pseudo-dominance, if the recessive allele starts expressing, obviously the female is going to have the disease. Can I say the small person has started behaving like a big person? The small person has suddenly started dominating. Is it actually real dominance? No, he's a small x. He's a small x, but he started showing you dominating features, pseudo-dominance. He's trying to be big in life. So if the recessive allele starts expression, that is known as pseudo-dominance. It is number one seen in hemophilia, example number one. Guys, it is also seen with red-green color blindness. Red-green color blindness can also show you this pseudo-dominant phenomenon. Coming on to the next concept, a very famous question that you get in your previous years, what is genotype and what is phenotype? Now, for example, you get genes from whom all? You get genes from your mother and genes from your father, and obviously genes from the rest of your family also, it's passing on in the family. So, genotype refers to your genetic makeup. Whatever genes you have got from your mother and your father, that is your genetic makeup. But tell me, if your mother has brown hair and your father has black hair, what color hair will you have? So basically, you got the genes for brown hair also, you got the genes for black hair also. But will you show both? You can't show half and half. You're going to show one expression. So what is going to be the final expression? That is going to be the phenotype. That is the difference between genotype versus phenotype. So genotype just means that I have a set of genes, some from my mother, some from my father, but they're all in me. But which of them will I express? The expression of the genes is going to be known as the phenotype. I hope it's very easy to learn. Yes? So you must have seen that you and your sibling, you might not have the same hair color, you might not have the same eye color, you might not have the same skin color. So although you have the same genes, you got the same genes from the same set of parents, but your sibling shows you a different expression and you show a different expression, because the genetics is the genotype and the expression is a phenotype. Very, very important PYQ. Moving on to the next set of definitions. What is pleiotropism and antagonistic pleiotropism? Firstly, when I say pleo, something different is going to happen. So for example, there is a single gene and it has different effects. I'll give you an example. There's a very famous example that you have for sickle cell anemia. So in sickle cell anemia, everyone I think knows that there is a mutation at the beta 6 position. at the beta 6 position, there is a mutation. So what do you expect? I'm not going into details right now, but at the beta 6 position, one amino acid is going to change for another. So glutamate is going to change for valine. How do you learn that? Glutamate is going to go and valine is going to be welcome. That is how you learn sickle cell anemia, that glutamate goes and valine is welcome. So that is happening in sickle cell anemia. But now guys, tell me, what do you expect? Sickle cell, you will expect that this person has formation of one thing known as sickle cells. But is that the only thing happening over here? No. Don't you know, along with that, these patients also have a lot of vascular crisis or occlusion of the blood vessels also occur. There is involvement of the spleen, there is involvement of the brain, there is involvement of the bones. So basically, there was a problem in a single gene, and how it has resulted in so many different problems, not only blood problem, but problem all over the body. I'll give you another example. For example, you've heard of phenylketonuria. So in phenylketonuria, you must have seen that there is a very different smell of the urine. You must have read that in biochemistry. In phenylketonuria, there is a mousy or a musty odor. Along with that, you must have read that there is skin pigmentation problem also. So see, it's the same phenylketonuria, but there's a problem in the urine also, there's a problem in the skin also. So single problem, but multiple effects are seen. Single gene and different effects are seen. That is why we called it pleiotropism. Then what is antagonistic pleiotropism? So first you will say pleiotropism definition remains the same. There is a single gene, okay, and that single gene is going to have different end effects. Perfect. But after that, what is the meaning of antagonistic? Antagonistic means some of those effects are going to be positive for us, some of those effects are going to be negative for us. Means, for example, there is a P53 gene. P53 gene is your policeman. So one good thing that it does for us is that it is not going to let tumors happen. Isn't it a tumor suppressor gene? So it's a policeman. Policeman means it protects you. It does not let tumors happen. But at the same time, it also stops a lot of cells from dividing. So basically, some of the effects are going to be good for my body. Some of the effects are bad for my body. So I say that is going to be, the two effects are opposites of each other, antagonistic pleiotropism. So remember, pleiotropism word means the same. One gene, many problems it is causing, and if those problems are some good, some bad, then they are going to be antagonistic. Moving on to the next one. What do you understand by mutations? Now, this is a topic which I have also taught you in the genetics part of bacteriology, that is the general microbiology, because it's pretty much the same, you read it anywhere. So we'll quickly repeat it here also. First and foremost, when you talk about mutation, you will be asked about the definition. Mutation is defined as a permanent change in the DNA. Mutation is defined as a permanent change in the DNA. And when I say permanent, permanent means irreversible. That is a question that you will get. Mutation is irreversible. Once it happens, it is for a lifetime. Do you know what are the two types of mutations that we have? The two broad categories. There is something known as a point mutation, and then there is something referred to as a frame shift mutation. There is a point mutation and there is a frame shift mutation. So let's know the difference between both of them one by one. Let me start my story with a point mutation. So see, the name only tells you something is going to go problematic in one point. So let me draw one entire sequence for you. Say just a random sequence, guys. You don't have to learn this. Obviously, I'm just telling you from a very general point of view. This is a nucleotide DNA sequence. Suddenly I say there is a problem at one point. Means this one nucleotide over here will be replaced by another nucleotide. One nucleotide over here will be replaced by another nucleotide. So is it happening everywhere? No, it's happening just at one point. So please remember, point mutation is going to be replacement of one nucleotide by another. Replacement of one nucleotide by another. Now the next question that they'll ask you is, what happens because of this? There are three situations that can happen. The first one is nothing happens. Good for us. Means silent mutation. problem hua, mutation happened, but ultimately nothing happened because of it. I did not have any signs and symptoms. I'm so happy because see, when a mutation happens, I'm very, very scared. What is the disease that I'm going to have? But God was so lucky. God was so generous. I was so lucky that nothing has happened. There is no signs and symptoms that I've got. So I'm going to be very, very happy over here. No signs and symptoms, no disease. The second situation is known as a missense mutation. What do we mean by a missense mutation? Please remember, missense means the sense has changed. So I'll give you an example. For example, a case of sickle cell anemia. What has happened in sickle cell anemia? Guys, a mutation has occurred because of which normally which hemoglobin do we have? We have adult hemoglobin. But now what hemoglobin will these people have? They will have sickled hemoglobin. So has the sense changed? Instead of having adult hemoglobin, the person has started having sickled hemoglobin. So the sense has changed, isn't it? That is known as missense mutation. Coming to the third one. What is nonsense mutation? So please note, nonsense mutation is seen in a case of thalassemia. Nonsense mutation is seen in thalassemia. When I say thalassemia, I am by default referring to beta thalassemia. Okay, so now what happens in beta thalassemia? If I ask you, even though if you've not read anything about hemat right now, thalassemia means nothing is going to be produced. The beta chains have stopped being produced. No sense at all. There is no production. That is what I mean by nonsense. And when would the production stop? Do you remember in biochemistry we study about 3 codons, UAA, UAG and UGA. What codons are these? I think everyone has guessed it very, very correctly. These are the stop codons. They are the red light. They are the stop signal. If at any point of time, UA, UAG and UGA, that is how you say that, UAA, UAG, UGA. If these 3 codons come, means it's a red light. Nothing is going to be produced. So imagine you ended up doing some point mutation, as a result of which there is going to be, so G got replaced. So for example, now you have UAA. That's a stop codon. The production of everything is going to stop. So simple. Whatever is happening at one point, and as a result of the formation of these, the production of everything will stop. So look at the difference between these two. See, in one I'm saying there is no production at all. No hemoglobin will be produced. That is known as beta thalassemia nonsense mutation. In one I'm saying hemoglobin will be produced, but the sense has changed. Hemoglobin is produced, but it is a different hemoglobin. That is hemoglobin S, sickle hemoglobin. So remember, point mutations, guys, are of 3 types. One is a silence mutation, missense mutation, nonsense mutation. Learned? Now we move on to the next one. What is a frame shift mutation? So let's study about that. Please remember, first you need to understand what is the concept of a frame. Then I will tell you how the frame is shifting when there is a mutation. So first, let's understand a frame. Let me again draw something. Let us draw CAG, CGG, CGG again, CGA, then GAG, your wish, whatever you want to write. One long sequence. Now I realize over here that I was reading, why did I read it out? Not to waste your time. CAG, CGG. Why am I reading it like this? Because I have written hardly 10, 15 nucleotides. I have all the time in the world. The body does not have so much of time to sit and read alphabet by alphabet like that. No. The body will say, I am reading it like a triplet. I am going to read it like a triplet. So CAG, frame number 1. This is said to be frame number 1. CGG, frame number 2. Another CGG, frame number 3. CGA, frame number 4. Body is reading it as frames of trinucleotides. That is one frame. Trinucleotide means what? 3 set is 1 frame. Now I say by chance, this got deleted. There is this 1 codon in between that got deleted. Is there a problem that is going to happen? So for example, there is a deletion of the nucleotide, of any one nucleotide. So let me now mark the frames. The first frame is remaining the same. The second frame has become GGC now. The third frame has shifted further. The fourth frame has shifted further. Do you see a shift in the frame that has occurred? And that is exactly what I'm talking about. This is known as frame shift mutation. Remember, this could happen because of deletion. This could also happen if I add another person in between. If I add, then also the same shifting will happen. So either because of deletion or because of insertion of the nucleotides. And one very important example of this is again beta thalassemia. So now when I'll be taking you all the way to hematology and talking about the genetics, you will realize that beta thalassemia can show you the previous one. That is, it can show you the nonsense point mutation also. And beta thalassemia can show you frame shift mutations also. That is the reason that they tell you or give you a question specially on the genetics of beta thalassemia, because it shows you a lot of things that you have to know. Having said that, yes, we finished with all our basics, and I'm going to give you a 2-minute summary of all of this. The first question that we did, how many genes are there? 20,000 plus. What are the parts? The coding part is exon, the non-coding part is intron. Which is predominant? The intron is the more predominant part. The introverts are more predominant. Coming to the next, how do you define the locus? How do you define the address of a particular gene? You had to remember the mnemonic CARBs. Chromosome, number, that is C, then A for arm, R for region, band, subband. Chromosome, arm, region, band, subband. How many alleles does every gene have? One gene has 2 alleles. If I write it as a capital, it is known as dominant. If I write it as a small, it is known as recessive. When there are 2 dominating people in the same room and both of them are talking, what do you call it? Both of them are talking, that is codominance. Famous PYQ. That what are the 2 codominant examples? AB blood group and HLA gene. When a small person fakely starts becoming dominant, when a small person starts acting like a dominant person, what do you call it? Pseudodominance. One very famous disease for that is hemophilia can show it. Coming to the next, what is genotype versus phenotype? Genotype is geno, that is, it's the genetic makeup. Phenotype is going to be the expression of that genetic makeup. Coming to the next definition, what do you mean by pleiotropism and antagonistic? One gene having many effects is pleiotropism. One gene having many effects is pleiotropism. But if some of those effects are positive and some of them are negative, it is antagonistic pleiotropism. What is mutation? Mutation is a permanent change in DNA. If it occurs at one point, it is a point mutation. Point mutation is of 3 types. That is, when no problem happens, it is silence. When the sense is going to change, like in sickle cell anemia, it is missense. And when the production only stops, it is going to be nonsense. The other one that you have is a frame shift mutation, where I told you that because of any addition or deletion, the entire frame is going to shift. And the example for that is also beta thalassemia. With this, we wrap up all our introductory and conceptual part of genetics, because now we'll be starting with the disease part of it. Having discussed all the concepts, let's start now with the genetic disorders. So I've got you a basic classification of these genetic disorders that you have to know. The first set of them are referred to as the single gene defects. So when I say there is a single gene defect, we have 2 things under it. Primarily, we have something known as the Mendelian disorders, and then we will be having the non-Mendelian disorders. These are what are coming under the single gene defects. But if by chance this question, because it has come in the paper once earlier, that if you had to select one of the most common and the important single gene defects, then your answer is going to be the Mendelian disorders. So yes, single gene defects come with all the Mendelian and non-Mendelian things. Then we'll have chromosomal disorders, which you all know, that is Downs and Pettau syndrome. And then we'll have multifactorial. So actually, I'm going to finish this aspect of genetic disorders first, and that is going to be multifactorial. What do we mean by that? Please remember that when we say multi, there are multi, matlab many, and factorial means factors. There is multiple factors that are going to be involved. So we just can't blame the genetics. It is not just a genetic defect, but along with that, there are going to be many environmental factors which are also going to play a role. I'll give you an example. You might have seen that diabetes mellitus and hypertension, they run in the families. There is obviously a genetic association, but does everyone, like all 20 people in the family, will have it? No. Some people will have diabetes, some will not. So is genetics alone going to play a role? Of course not. Along with genetics, what is the lifestyle of the person? Sedentary lifestyle, what are the eating habits, what is going to be the exercise? So all of that also plays a role in the development of diabetes and hypertension, right? So can I say diabetes and hypertension are multifactorial disorders? Because genetic problems are also there, environmental factors are also there. Do you think they are going to ask you such a simple question? Because this much even the common population of our country knows. They will ask you something different, and that is, what are the other things that come under it? Remember, cleft lip, cleft palate, and congenital heart diseases. Cleft lip, cleft palate, and congenital heart diseases. These are the ones which are now very famous for following a multifactorial inheritance. This is where a question is going to come to you. Lip, palate, clefting, and congenital heart diseases. Okay, having said that, now we can go back. Your multifactorial is done. Now we are going to start one by one, and we are going to start with number one, the Mendelian disorders. I think if I have to make a list of all the Mendelian disorders, you guys already know their names. Autosomal dominant, autosomal recessive, X-linked recessive, X-linked dominant, and Y-linked. Now, there was a previous year question where Y-linked has been called as Hollandric inheritance. How did I learn that? Y stands for males, androgens, males. So, Hollandric will remind you of andro. That is how you will learn it. Hollandric will remind you of andro. Andro means males. So, that is how we've learned it. Let's start one by one. The first thing that I'm starting with is autosomal dominant and autosomal recessive. Let's do their rules, then let's do the mnemonics for their examples, and let's study a few diseases in detail. The first thing that you have to know is the difference between autosomal dominant and recessive. But before that, I hope you remember, if someone asks you what is the most common mode of inheritance, what is the most common mode of inheritance, and that is going to be autosomal dominant. But if I change the question and I say, what is the most common mode of inheritance for the inborn errors of metabolism? For the inborn errors of metabolism, and that is going to be autosomal recessive. So you must have heard of so many inborn errors of metabolism. Have you heard of lysosomal storage diseases, glycogen storage diseases? Yes, all those metabolic problems, all of them are going to be autosomal recessive. But if they ask you overall as a blanket question that what is the most common mode of inheritance known to the human population, that is autosomal dominant. Now let's start with their differences. Please remember, autosomal dominant has an adult onset. Adult, or you can also say adolescent onset, means the child is not going to have symptoms too much at the age of 5 or 7. Symptoms start later on. So the onset is going to be an adult or adolescence, whereas autosomal recessive disorders, they tend to have a childhood onset. They tend to have a childhood onset. How did I simply learn it in case you were not aware of this already? AD, AD, AD. Autosomal dominant is going to have an adult or an adolescent onset. Easy to learn? I hope yes. So repeating, it is going to have AD, AD, AD. Now talking about something which students just read and somehow mug up and never ever understand what they are talking about, but I'll explain that to you. First and foremost, autosomal dominant can have something known as incomplete penetrance, whereas autosomal recessive is going to have complete penetrance. Similarly, expressibility is going to be variable in autosomal dominant and expressibility is going to be 100% in autosomal recessive. What all did I write? If I just had to mug it up, I realized autosomal recessive has everything 100%. Penetrance is also coming out as complete and expression is also coming out as complete. That is my ratta. But what is the meaning of it? Let's go one by one. Let's understand the term penetrance first and then we'll go to expressibility. So what do we mean by penetrance? Let us draw one family diagram and understand it. Okay, one entire family chart we will draw and we will understand it. So please remember, this over here is the grandfather. This over here is a grandfather and he has some diseased gene in his system. So basically, this is the grandfather and he has some diseased gene in his system. So there is a problematic gene defect that is present in his body, and because of that, he is showing signs and symptoms. Disease is also present. He has now given birth to, let's say he has given birth to a kid and that's a boy. So he has given birth to a boy, which means that that boy is also going to get the same gene. That boy is also going to get a same gene. And if he's got the same genetic problem, he will also show you the disease. This boy further had another kid, a further tiny little kid. Again, the gene has gone forward. You will say again the gene defect has gone forward. So the defect is there. But suddenly, to your surprise and luck, the disease did not show up. What did you realize? That the gene has still gone forward, but the disease did not happen. Means, for example, if I take it in a better way, if I give you some information and you learn it and you solve your MCQ, that is, I have given the information and information has penetrated into your brain. That is why you could solve the question. Again, I gave you a little bit of information. It went into your brain. That is why you could solve the question. But if you are listening to this lecture in a sleepy mode, half sleepy, lying down somewhere, I am giving you all the information, but is it going into your brain? Is it penetrating? It's falling on your ears, but is it going into your brain? It is not penetrating into your brain. That is what you mean by incomplete penetrance. That is what you mean by incomplete penetrance. What is incomplete penetrance? It means that the gene defect is there. The defective gene is there, but is the disease going to occur? The disease is not going to occur. So I have given the information to you, but were you able to get it into, penetrate it into your brain and solve questions? No, that was not possible, right? So this is one thing. And who shows you this kind of incomplete penetrance concept? Sometimes autosomal, not always, sometimes this happens. This is a rare kind of an event, but whenever this will happen in autosomal dominant. This can never happen in autosomal recessive. Recessive has complete, means if I have given you some information, you will always get it into, penetrate it into your brain. So if I have given a gene, it will always cause a disease. Autosomal recessive is complete penetrance. Now let's understand the meaning of the word expressibility. So, for example, let's take the same example. Expressibility means it is going to be expression. Means I have given the same lecture to 100 students. The same 100 students are listening to the same genetics lecture, but some of them will be able to solve 10 questions. Some of them might do some silly mistakes and solve 8 questions. Some of you might do more silly mistakes and solve 6 questions. So see, the same information has gone to all of you, but are all of you showing me different expressions? Because everyone's brain is different. Everyone's grasping ability is different, right? So when I say it's the same disease, but there are going to be different expressions. There are going to be different expressions. I'll give you a very famous example of a disease called neurofibromatosis. We will be studying this in more detail. For the time being, I want to tell you that in neurofibromatosis, there are a lot of things. Neuro means there's some neural problem. There are neurofibromas. There are skin problems. There are eye problems. So for example, if I have 3 people having neurofibromatosis, so you will say this person 1, 2 and 3, if all of them have neurofibromatosis, all of them should show you the same symptoms. But no, this person showed you neurofibromas, this person showed you neurofibromas with skin problem, this person showed you neurofibromas with eye related problem. So it's the same disease, repeating, it's the same disease, but in different people, it's showing me different expressions. So I'm giving you the same lecture, but everyone is going to solve different number of questions. That is a concept meaning variable expression, and that is also what you see with autosomal dominant. Did you notice, or did I just tell you about neurofibromatosis? Neurofibromatosis is an autosomal dominant disorder. That is why it can show different expressions in different people. So coming all the way back, there is an incomplete penetrance and a variable expression that you see with autosomal dominant. Everything incomplete, variable, everything variable type is in autosomal dominant, whereas in autosomal recessive, expression is 100%, means if there's a disease, all the people in the population will show you the same kind of phenomenon. I'll give you an example. Have you all in biochemistry read about something called alkaptonuria? I'll be talking about it. Alkaptonuria is what color urine? Just one quick answer to that. Alkaptonuria is black urine. Everyone will show black urine. 100% of the people will show black urine. That is what I wanted to tell you. So please remember, everything variable, incomplete penetrance, variable expression, all these variable things are to do with AD. Whereas everything 100%, that is going to be related to AR. Having discussed this, let's move forward because now we need to go ahead with examples. And before I start with examples, I know mnemonics are going to be handy, but sometimes we forget mnemonics in the exam. Happens with all of us. Then you should have a concept. If mnemonics should not help you, then concept will help you. In most of the examples in autosomal dominant, you will realize there is going to be a structural gene defect. There is going to be a structural gene problem. So some structure of the red blood cells, structure of the bones, collagen, structure of cartilage, all structure things are going to go problematic in your body. Whereas in autosomal recessive, you will see there will be a lot of enzyme deficiencies. You will realize there will be all metabolic disorders like lysosomal storage disorders, glycogen storage disorders. So all those enzyme and metabolism things will usually be AR, and all the structure related problems are going to be AD. On that note, let's start with the examples of autosomal dominant first. And for that, I have got you a mnemonic. He has a very dominant and powerful father. See, because we are learning dominant, I have kept the word dominant in it. So I'll write it down one by one. What is it? So first, he has. So I'll start one by one. He is going to stand for all the he things. Means it is going to stand for all the hereditary things. Everyone's heard of hereditary spherocytosis. Hereditary spherocytosis. What is hereditary spherocytosis? It's a problem in the red blood cells, right? Red blood cell problem. Next, we have something called another he. Hereditary hemorrhagic telangiectasia. Hereditary hemorrhagic telangiectasia. If I break the word, what kind of a disorder is it? Telangiectasia. It's going to be a blood vessel problem. Again, HE for hereditary. Have we all heard of something called HNPCC? What is HNPCC? Hereditary non-polyposis colon cancer. Non-polyposis. There is no polyp and still there is colon cancer. That is what you call as HNPCC, which is given another name called Lynch syndrome. So repeating all of this for you once again, we have all these hereditary things, means HE for he, that is hereditary, hereditary, hereditary. The next thing is going to be he has. So what is the next H that we have over here? Remember, there is one disease in the brain that is known as the Huntington disease. And there is one disease in the heart which is known as hypertrophic cardiomyopathy. So one disease in the brain, one in the heart, that is hypertrophic cardiomyopathy. He has a very, so a means adult, something adult, autosomal dominant polycystic kidney disease. This means there must be an autosomal recessive polycystic kidney disease also. Yes, there is, and this is in the name. The autosomal dominant one will obviously come in this list. Okay, he has a very, so V is going to actually stand for two things. There is a hemat problem called von Willebrand disease, and there is a syndrome which is known as VHL syndrome. For those who know, very good. For those who don't, VHL basically is von Hippel-Lindau syndrome. We will be studying it in a lot of places when we go to systemic path, VHL. And for the time being, I can tell you, since VHL has 3 alphabets, the chromosome that is deleted is going to be chromosome 3. That has come as a previous year question. Repeating, VHL has 3 alphabets, so chromosome number 3. Okay, so he has a very, what is the next part? A very dominant and powerful father. So first, when I write the word dominant, now this is exactly where you need a little bit of extra patience, I would say. More than attention, you need a little bit of extra patience. So he has a very dominant. D for there is muscle dystonia. There is going to be muscle tone problem. So dystonia is going to be the issue over here. Next, O for osteogenesis imperfecta. Osteogenesis imperfecta. Did I just tell you that autosomal dominant was all structure related problems? So put your mind into it. Muscle is a structure, muscle problem. Osteogenesis, osteobone, bone problem. Okay, next we have a disease which I will be telling you in a lot of detail, and that is known as Marfan syndrome. That is known as Marfan syndrome. Next we have something known as intermittent porphyria. Intermittent porphyria, very important for you to know in biochemistry. N stands for neurofibromatosis 1 and neurofibromatosis 2. There is another N over here which will stand for Noonan syndrome. Then we have something known as A for achondroplasia. Achondroplasia. See again, cartilage. Cartilage is structure, cartilage problem. And T for tuberous sclerosis. T for tuberous sclerosis. Tuberous sclerosis I will be teaching you in a little bit more detail shortly. But for the time being, what is this dominant mnemonic that we have? Muscle dystonia, osteogenesis imperfecta, Marfan, intermittent porphyria, NF1 and NF2, achondroplasia, Noonan syndrome, tuberous sclerosis. So is this mnemonic over? No, he has a very dominant and powerful father. The last part of this mnemonic is powerful father. So when we say powerful, P stands for pseudo-hypoparathyroidism. Pseudo-hypoparathyroidism. And FA is going to be everything that comes to your mind in medicine, surgery and path with to do with FA. So have you heard of a disease called FAP? In surgery you will, and in path also. There is something known as familial adenomatous polyposis. Lots of polyps in the intestine. Familial adenomatous polyposis. The next FA is actually a little bit of variation in FA, and that is Li-Fraumeni syndrome. Li-Fraumeni syndrome, and you will be studying this shortly in the neoplasia chapter. Li-Fraumeni syndrome is a mutation in your policeman. It's a mutation in P53. Finally, we come to another FA, which is going to be familial hypercholesterolemia. It is familial hypercholesterolemia. So having said that, you realize that your mnemonic is finally done, but we have a lot of things to study in detail. So let's first quickly do what is the mnemonic. He has a very dominant and powerful father. So the word dominant will remind you of this dominant mnemonic. He has a very dominant and powerful father. He will have everything to do with all these hereditary things. H is going to be the Huntington as well as the hypertrophic cardiomyopathy, one brain, one heart. A for autosomal dominant PKD. V for the two V's, that is von Willebrand disease and VHL syndrome. Then he has a very dominant, so D for all, now onwards all the structural problems. So there's dystonia in the muscle, bone problem, osteogenesis imperfecta, Marfan syndrome, intermittent porphyria, NF1 and NF2, cartilage related problem, achondroplasia, Noonan syndrome and tuberous sclerosis. He has a very dominant and powerful pseudo-hypoparathyroidism and all the FA, that is familial adenomatous polyposis, Fraumeni syndrome, familial hypercholesterolemia. Which are the ones that you have to know in detail? A short thing about this tuberous sclerosis quickly. Do you know what is the other name for tuberous sclerosis? And I'll show you a classical picture on how the question is going to come. When we talk about a disease called tuberous sclerosis, please remember this tuberous sclerosis is given another name called the Bournville disease. Not the chocolate that you all are fond of, but yes, the Bournville disease, or you can say the Bournville syndrome. That is what is tuberous sclerosis. And why does this occur? So tuberous sclerosis occurs because of TSC. What did I say? It occurs because of TSC gene. So there is actually something called TSC1 gene, and there is something called TSC2 gene, and if you go by their chromosomes, they are present on chromosome number 9 and chromosome number 16. Now the question that comes in the paper is, what is the protein that TSC1 gene makes? That is known as hamartin. And what is the protein that TSC2 gene makes? And that is going to be tuberin. And how have students learnt it is hamara tumhara. So TSC1, TSC2, smaller number that is 9, bigger number that is 16, and the proteins have been learnt as hamara tumhara. So hamartin and tuberin, right? But one very classical clinical question that comes, and now I want to tell you, because it has something called hamartin protein, clinically there are two things you have to watch out for. There are going to be multiple hamartomas in the body. If you guys have read neoplasia chapter, you know hamartomas are tumors. If you've not read neoplasia chapter, right now just mug it up a little. Hamartoma is a tumor that occurs. That is how you will learn it, because hamartin proteins or hamartomas. And other than that, you see such kind of hypopigmented lesions called the ash leaf macules. So most of your questions, when they want to give you tuberous sclerosis, they will say that there's a person suffering from multiple hamartomas, and they will say that there's a person having these ash leaf macules, hypopigmented, or this picture will be given. They will ask you the gene, or they will ask you something like Boneville syndrome, hamara tumhara. So Boneville, the chocolate, half chocolate I'll keep, half chocolate you can keep. So that is half chocolate hamara, half chocolate tumhara. That is what is Boneville or tuberous sclerosis. Well, having said that, the next thing that you have to know in detail is going to be the much asked Marfan's syndrome. So let's start the story of Marfan syndrome. It's one of my favorite genetics to explain, because it's a very real, relatable thing that you and I, all of us, have gone through in our student life. So let's start and study first what is Marfan syndrome. When I say Marfan's, they will ask you which is the chromosome that is going to be affected. It is chromosome number 15. So chromosome number 15 is affected. On chromosome number 15, which gene is affected? Please remember, there is something called fibrillin 1 gene. Fibrillin 1 gene is going to be affected, and we write it as FBN1. Fibrillin 1 gene. Now tell me, if chromosome 15 has a problem, means chromosome 15 has a defect, on that chromosome fibrillin 1 gene has a defect, which protein will have a defect? Common sense. Fibrillin 1 gene will obviously make fibrillin 1 protein. Fibrillin 1 gene will make fibrillin 1 protein, and this means that is also going to be defective. So if I ask you a simple one-liner of your previous years, what is the protein defective in Marfan syndrome? That is fibrillin 1. But then another question came, what is the protein affected? See, I've changed the term. Defective is definitely fibrillin 1, but who is affected is elastin. Why so? Because now I'll tell you the story of you and your best friend. So I've seen so many times on Telegram and on social media groups, people keep searching for study partners, and I always wonder that, do you sit and chat with study partners, or do you actually study? That's a big question mark in my mind, which I think I know the answer to also. But yes, having said that, for example, you and your best friend. So you and your best friend are fibrillin and elastin. So let me draw this. There is one best friend, and that person is known as fibrillin. And then there is another person very closely bound, and that other person is known as elastin. Now tell me one thing, whenever you sit down with your best friend or your roommate or your batchmate and you decide that we are going to study, either both of you study together or both of you go out and party. You don't study, right? So tell me, if by chance this fibrillin has undergone a defect, your friend says that today I don't want to study, I am going out and I'm going to go and watch a movie. Who is not studying? Fibrillin is not studying. You want to study. You are elastin. You are the good person. You want to study, but you say, ma'am, my friend is going out for a movie. My friend is not studying. Will you be able to sit back and study? Obviously not. Can I say elastin will get negatively affected? Elastin did not have any problem, but because it saw that my friend fibrillin is not studying, then I will also feel that let me also watch Netflix and not study. Have you understood? So if I ask you a simple question, that in Marfan syndrome, what is the protein that is defective? The word defective comes, fibrillin is defective. But in Marfan syndrome, what is the protein that is affected? There, that is when you will select elastin. Be so careful while answering these questions. The defect is in fibrillin, the effect is in elastin. And do you know what is this beautiful concept known as? This is known as dominant negative. This is said to be dominant negative. And so many students write to me that what is dominant negative, please explain. But from today onwards, if you remember the story of you and your study partner, best friend, you will always remember. Means who has a dominating problem, who is the autosomal dominant defect. The dominant defect is in fibrillin, but who is getting the negative effect? The negative effect is going to be on elastin. So dominant, problem, negative, effect. Together you call it dominant negative. And that is what you need to understand over here. So again asking, what is the protein defective? Fibrillin protein is defective. And lastly, if I ask you, what is the protein that is going to be negatively affected? And that is going to be elastin. All your questions in one place. Question 1 of the previous year, chromosome 15, gene, fibrillin 1, protein defective, fibrillin 1, protein affected, elastin. Okay, after this you would obviously want to know something from me, and that is that what exactly are the clinical features and how are we going to analyze this. So let me tell you, if I go into a little bit more detail in this diagram only, I will realize that you know what this fibrillin does. This fibrillin has a property that it has held on to something. See, this fibrillin had kept something, your friend had kept some notes with himself. Okay, your friend had kept some notes with himself which he was not showing you, he was hiding these notes from you. So please remember, fibrillin is going to control something known as TGF beta. Fibrillin has said, I am keeping all these TGF beta notes with me. Suddenly when fibrillin goes out for a movie, you start seeing those notes. Fibrillin has gone out for the movie, fibrillin has gone defective, and you suddenly see that, okay, TGF beta levels are increasing, and that is why this disease has occurred. So please remember, whenever there is a fibrillin 1 defect, whenever your friend has gone for a movie, you find out that, okay, my friend was reading some notes which he was hiding from me. So what is activated? TGF beta levels are overactivated. And can I say that this is going to result in all the signs and symptoms? So if I want to know the treatment of Marfan syndrome, nowadays for the treatment of Marfan syndrome, we have something or drugs against TGF beta. Do you know any drugs against TGF beta? Losartan. Losartan is going to be a drug which is going to go and act against TGF beta. Everyone's understood? TGF beta was that hidden notes copy that your friend was reading, and now because he had gone out, he has been defective, those notes have come to you. You've seen that, oh, TGF beta notes were there. And how will you treat this disease? By a drug against TGF beta, that is losartan. So all in all, having said that, what symptoms am I talking about? So let's start with the diagnosis of Marfan syndrome. Please remember, for the diagnosis of Marfan syndrome, we are going to use something known as the revised Ghent's criteria. We are going to use something called revised Ghent's criteria, which basically says that first and foremost, you should have a family history in the patient. Why am I focusing so much on family history? Because Marfan syndrome is autosomal dominant, so obviously it's coming from the family. So first you have to find out about the family history. Second, you will find out about the clinical features. Is the patient having, there's a boy, for example, there's a 15-year-old boy who's come to you. You have to look at that 15-year-old boy and see that does he have the symptoms? So yes, if he has the symptoms, you will ask about his family. Anyone in your family has similar symptoms? He says yes. When he says yes, what is the genetic analysis you would want to do? You will do fibrillin 1 gene analysis. You will do testing for fibrillin 1 gene. So simple. What is revised Ghent's criteria is such a common sense thing. The patient comes to me, I have to look at his symptoms. Then after looking at his symptoms, I have to ask him, does anyone else in your family have those symptoms? And if yes, then I am going to go and test for the fibrillin gene. So what symptoms am I talking about? What clinical features am I talking about? Very simple. When I say Marfan's disease or Marfan syndrome, the mnemonic is Marfan's syndrome. So let's begin. When I say M, there is something known as mitral valve prolapse. Mitral valve prolapse, please remember, is going to be the most common cardiac abnormality that you have in Marfan syndrome. The most common cardiac abnormality, mitral valve prolapse. Coming to the next, another cardiac problem, A for aortic dissection. How is it sounding? Aortic dissection means what? The aorta is going to tear open. If the aorta is going to tear open, it's obviously sounding very, very bad. This shall be the most common cause of death. Aorta shall tear open. The next alphabet is R. So what is with R? Eye problem. Eye means there is retinal detachment. There is retinal detachment. Coming to the next, there is F, which is one of the most important things, because didn't I just tell you the story of fibrillin and elastin and how elastin is having a problem, elasticity is having a problem. So your joints in this patient can be moved in any direction. There is going to be a freely movable joint, and here they ask you which is the most common joint that is going to be affected. The most common shall be the thumb joint. The most common is the thumb joint. Okay, so moving on, what is with Marfan, what is with A? So you will realize, and I'm going to show you a picture right now. Have a look at this picture first. Look at these fingers. Can you see them? This is known as arachnodactyly. So what did you realize? Look at the fingers. They are long, long fingers like a spider. So please remember, guys, this is exactly what you will be asked. This is known as arachnodactyly. And by arachnodactyly, what do you mean? These are long fingers. In fact, you know, what do they ask you? These long fingers are also said to be spider fingers, that they look like spiders. So these are going to be spider fingers. Okay, now there's another recent A that has been added over here, which I want all of you also to note, and that is high arched palate. They also ask you about high arched palate. So there's another A added over here, high arched palate. Where are we? Almost close to the end. Marfan. These are very, very tall people. So for the mnemonic, we have made it 9 feet tall. For the mnemonic, we make it 9 feet tall. So repeating only Marfan, the syndrome part of it is left. So M for the most common cardiac problem, that is mitral valve prolapse. A for the problem that is going to result in death, aortic dissection. R is a eye finding, retinal detachment. F, freely movable joint, and that joint is most commonly the thumb. A for the very famous picture that you have, arachnodactyly, the long, long fingers and also high arched palate. And N for a very, very tall individual called 9 feet tall. But that does not finish off your mnemonic, because this is Marfan's, and beyond Marfan's, either you can call it Marfan's disease, either you can call it Marfan's disease, or you can call it Marfan's syndrome. That is how I've learned it. So everything with Marfan you have done up till now. When I talk about a syndrome, remember these patients can show you pigeon-shaped chest. Pigeon chest is also a finding that is seen, or with chest I learn sternum. That is how I've learned it as syndrome. That is, these patients can show you a pigeon-shaped chest or a defect in the sternum. And why do I call it dis? Because here comes a famous ophthal question. There is dislocation of the lens. There is dislocation of the lens, and I don't want to call it like this because all of us have read ophthalmology. We know that that is known as ectopia lentis. When we say dislocation of the lens, it is known as ectopia lentis. Let me draw the two eyes. The next question that will come to you is, in which direction does it get dislocated? It goes up and out, up and out. So what is up? Up means supero and out means temporal. What is the direction of the dislocation that we have? That is going to be superotemporal. How will I learn this? See, guys, we are talking about Marfan, fan. Where is a fan present? Fan is always up on the ceiling. Where is fan present? Fan is going to be up on the ceiling. When a fan will move, where will all the air go? The air will go outside. So that will be temporal. So remember, the fan is going to be present up and the air is going to go out. So Marfan syndrome is superotemporal. Because now in the exam, they will ask you which is the condition which shows you opposite, inferonasal, and that disease is homocystinuria. That disease is homocystinuria. How did I learn this? Homocystinuria. Inuria is going to have inferonasal. Repeating, inuria is going to have inferonasal. This is also a very important question for your exam. So simple. Marfan, fan is up and out. So Marfan is going to show you superotemporal, whereas homocystinuria is going to show you inferonasal, down and in, inferonasal. Okay, having said that, this was a basic about Marfan syndrome. If I have to give you a quick recall, mitral valve prolapse, aortic dissection, retinal detachment, freely movable joints, arachnodactyly with high arched palate, 9 feet tall. I call it syndrome because it is to do with sternum. I call it disease because it is to do with dislocation of the lens. Is that it? Well, not so. Let me tell you, there are, because I realized overall, if I had to see, you say, okay, there are cardiac problems also, blood vessel problems also, eye problems also, skeletal problems also. So if they ask you out of all of these, which is the most common clinical manifestation, which is the most common manifestation out of all of these, and that is going to be skeletal abnormalities. Out of heart and blood vessel and eyes and skeletal, remember, skeletal abnormalities are the most common overall manifestation, because of which the maximum signs are also to do with this. You don't have to read everything, you just have to focus on very two important signs that you get in medicine. So I've got you for your integration, because that is how the questions will come. There is something known as a Steenberg sign, and there is something known as the Walker sign. So now please remember, you've seen these pictures. What do you do in the Steenberg sign? You tell the patient that he has to fold his thumb. And see guys, when you fold your thumb and you close your fist, you will never see your thumb coming out of it. Very rarely in normal people it does if someone has very long fingers. But in most of us, if you close the thumb, if you close your fist, you will never see the thumb coming out. But do you see in this patient the thumb is coming out? Why? Because the fingers are very, very long. They have spider fingers, na? So if you see that the thumb is coming out of the hand like this, that is a Steenberg sign. What is the Walker sign? The Walker sign is again very thin, blessed people can do this normally also. You will tell the patient to take his hand and put it on his wrist. So he will be able to hold the fingers between the thumb and the little finger. So some, as I said, some very thin, blessed people can do that. That is between the thumb and the fifth finger, because the wrist and the arm, everything is so thin and so long, elongated. That is known as the Walker sign. So I have learned the Walker sign is the W for W. The Walker sign is the wrist wala sign. Is the holding the wrist in your thumb and little finger. That is the wrist wala sign. Whereas Steenberg sign is going to be the thumb sign. It is going to be Steenberg. You take the T. So Steenberg is going to be the thumb sign, whereas Walker, W for W, that is the wrist sign. Because all in all, we realize that the most common manifestation of Marfan's is going to be skeletal abnormalities. Well, having said that, guys, some extra questions also that I would want to mark over here, just two of them to end this discussion with. They also ask you that when it comes to pathology, and pathology basically means anything that you can see under the microscope. So here I've shown you on medicine part. I've not shown you anything pathology related. It shows you cystic medial degeneration of the vessel wall. There is cystic medial degeneration, and that degeneration. So you'll ask me, what is this cystic medial degeneration? Degeneration means something is going to degenerate where? Medial, blood vessel, tunica media. This means this is going to involve the blood vessel. And if something is degenerating, you know what is happening? Blood vessel has these cystic spaces. So you will say, how is it degenerating? There is loss of the elastic fibers. There is loss of elastic fibers, and they give you a question in pathology. What is a stain for elastic fibers that we have? That is VVG, that is Verhoff Van Giesen stain. So indirectly, if they say that you want to test for elastic fibers, what is the stain that you will use? Remember, if I want to pick up elastic fibers, everything over here is elastic. Elastin protein was affected. Elasticity of joints is affected. Elastic fibers in the blood vessel are affected. When they are lost, I will use a stain called Verhoff Van Giesen that will show me that, okay, elastic fibers are gone. If they are gone, means the blood vessel is degenerated. If the fibers, the main elastic component is gone, this means the blood vessel is degenerated. That is known as cystic medial degeneration. That is definitely a question that you expect when you're dealing with this pathology part of it. Another one last question for Marfan syndrome that I want to teach you is that I told you that it has a lot of things, M-A-R-F-A-N, every alphabet had something or the other. But now I told you that all of that Marfan syndrome was because of which genetic problem? It was because of fibrillin 1 gene defect. Yes, everyone remembers that? Because now I will ask you that is there anything to do with fibrillin 2 gene defect? And yes, that is known as congenital contractural arachnodactyly. Congenital contractural arachnodactyly. That basically means that this person will have something from birth. There will be some contractures, and predominant thing will be these finger findings. These arachnodactyly means the other things like the cardiac problem, the eye problem, those are not going to be there. Only and only the arachnodactyly part, this part, the spider finger part is going to be there. That is what happens with fibrillin 2. So it becomes very important whenever you talk about Marfan syndrome in the paper, pick up fibrillin 1. I hope everyone has got that concept, because now we are also moving on to the next disease. You remember we are doing all autosomal dominant disorders. He has a very dominant and powerful father. I've taught you tuberous sclerosis. I've taught you Marfan's. I also want to touch quickly upon neurofibromatosis and then we move forward. Neurofibromatosis means NF is how they write it. And I think everyone knows neurofibromatosis is of two types, that is neurofibromatosis 1 and neurofibromatosis 2. Do you know why are they called like this? Because actually the genetic problem, the name of the gene is only NF1 gene and NF2 gene. After the genes, they decided to call these syndromes. So NF1 gene and NF2 gene is the defect that will happen. So you will ask me their chromosomes. I will be teaching you all the chromosomes again in the neoplasia chapter. But please remember, NF1 is present on chromosome 17 and NF2 is present on chromosome 22. And a lot of students ask me how to learn this. Count neurofibromatosis number of alphabets. Some really bored person in life must have done that. But if you count the alphabets, it comes down to 17. Neurofibromatosis has 17 alphabets. That is why NF1 I say 17, and then NF2 is 2 times 2, that is 22. So NF1 is 17, NF2 is 22. And if they ask you what is the protein that it codes for, I think everyone knows. For neurofibromatosis, the protein is neurofibromin that is going to be there. And for the NF2, it is going to be the Merlin protein. For NF2, it's the Merlin protein. Well, having said that, your next question will be what are the manifestations? So first and foremost, as you can see the word neurofibromas or neurofibromatosis. So obviously, NF1 will have neurofibromas in it. NF1 will have neurofibromas. So if this is a neural tumor, what is the neural tumor in NF2? NF2 is going to have schwannomas. NF2 is going to have schwannomas. So one neural tumor to both. Next, both of them have a skin lesion which I'm going to show you, that is cafe au lait spots. Now let me show you what a cafe au lait spot is. This is how it looks like. These are pigmented lesions. These are referred to as the cafe au lait spots, and these are present both in NF1 and in NF2. Other than that, there is something in the eyes that is present, and these are very famously known as the leash nodules. These are known as the leash nodules. They are only present in NF1. They are not present in NF2. Very, very important finding. So you would want to ask me, what is a leash nodule? As I said, it's a very famous question in ophthal that you get. That's why I said it's there in the eyes. And what exactly is it? It is pigment in the eyes. Tell me something. Which part of the eye anyway has a pigment? Which is the colored part of your eye? Iris. There is more color in it. So this is a pigmented iris hamartoma. This is known as a pigmented iris hamartoma. So repeating, there is going to be a pigment already in the colored portion of the eye. So that is pigmented iris hamartoma. That is a leash nodule seen only and only in NF1, not a feature of NF2. So if I say there's a patient, so this is how you differentiate. There's a patient with a neural tumor. They didn't tell you which neural tumor, some neural tumor, okay? That patient has pigmented lesions, or this picture is given. Cafe au lait spots are given. So right now it could be either of the neural tumor tumors. It could be both of them showing you pigmented lesions, but now they say that this patient has eye lesions called leash nodules. Now you know which NF are you dealing with? You're dealing with NF1. But why will I teach this to you once again when we go to the chapter of neoplasia? Because there must be some cancers also occurring because of it. Quick revision, guys. If I tell you about neoplasia, here only our life becomes so simple. NF1 versus NF2. NF1 had that eye problem, na? The eye, the leash nodule. So one more eye problem. There is something known as optic nerve glioma that is going to be there. NF1 is going to show you optic nerve gliomas. NF1 is also going to show you a very important blood cancer which you don't study much in medicine or in path, and that is going to be JMML. What is usually I've heard of AML, ALL, all those baby ones. This is another baby one but doesn't sound baby. The name is quite big. That is, baby means it occurs in children. Juvenile myelomonocytic leukemia. Juvenile myelomonocytic leukemia. So repeating, guys, once again, which is the most common leukemia you see in NF1 patients? In NF1 we see JMML, juvenile myelomonocytic leukemia. On the other hand, what all do you see in NF2? For NF2, we've got a very famous mnemonic called Miss Me. Now, what is Miss Me? M stands for MIS. What was the neural tumor that I told you over here? Schwannomas, right? So yes, there are going to be schwannomas, but multiple schwannomas. What you have are multiple inherited schwannomas. So miss is sorted. Multiple inherited schwannomas. Apart from that, what all brain tumors can be there? Meningiomas can be there, and ependymomas can also be seen. Ependymoma can also be noted. That is why I said miss me mnemonic. Let's talk about it. MIS means multiple inherited schwannomas. M for meningioma, E for ependymoma. All of these are seen in NF2. So now if I ask you a simple question, out of NF1 and NF2, which of them would be known as bilateral schwannomas? Common sense. Which of them will have another name called bilateral schwannomas? That is sorted. So NF2 is also known as bilateral acoustic schwannoma. That's the other name of this disorder. Now you know what is bilateral. Bilateral means both sides. Schwannoma is the name of the tumor happening. But what is acoustic? Which cranial nerve is affected? Cranial nerve number 8. That is why we say bilateral acoustic schwannoma. Then you'll ask me, what is the name of NF1? That has a name after a scientist. Von Recklinghausen syndrome or von Recklinghausen disease is how we define NF1. So let's do a quick recap. This will wrap up all our autosomal dominant disorders. Number 1, please remember, neurofibromatosis 1 versus 2 is named because the name of the gene is 1 and 2. 1 has 17 alphabets, so chromosome 17 codes for neurofibromin. 2 has 22, so chromosome 22 codes for Merlin. This has neurofibromas in it. This has schwannomas in it. Both of them have the skin lesion, which I just showed you, that is the cafe au lait spots, but only one of them has the eye problem. And that eye problem is going to be the leash nodules. The tumor is also related to the eye nerve over here. That is optic nerve glioma will be seen in NF1, and the most common leukemia is JMML. Whereas for NF2, you have to remember the mnemonic Miss Me. This same mnemonic I will be teaching you when we go to the CNS tumors. Having discussed the autosomal dominant disorders, let's start with the autosomal recessive ones. I told you that for all of them, we are going to go ahead with the mnemonic. So what is your mnemonic for autosomal recessive? And at present, you might feel that these are a little lengthy mnemonics. But eventually you'll realize that these are covering not just pathology but a great chunk of medicine. And if all the mnemonics are getting all your diseases under one roof, it's definitely a good deal, right? Having said that, for autosomal recessive, you have to remember a little lengthy but something related to food, so we wouldn't mind. It's pasta and fried rice. So fried rice I will call as fried chawal. And yes, along with that, there's something called big facts. So pasta and fried rice with big facts. So let's start. I've always told students also, never just cram up things like what is P, what is A. Try to make some link in your mnemonic, because in the exam, you all would agree with me, all the ABCD somewhere gets jumbled up, right? So when we talk about pasta, how I have learnt it is the first two, that is P and A, are enzyme deficiencies. So P stands for phenylketonuria. P stands for phenylketonuria. ketonuria, and A stands for alkaptonuria. A stands for alkaptonuria. So phenylketonuria, alkaptonuria. Can you quickly tell me what were their enzyme deficiencies? I hope you remember phenylalanine hydroxylase, very famous question of the previous years. PAH, phenylalanine hydroxylase. And you know how the examiner tries to confuse you? He will say that phenylketonuria is PKU gene defect. So many students believe that, okay, phenylketonuria must be P, K and U gene defect. No, it is a PAH deficiency. It is a phenylalanine hydroxylase deficiency. And I think everyone is aware what is the odor of the urine that we have. We have a mousy or a musty odor to the urine that you need to know. Mousy or musty odor, urine findings are very, very essential in biochemistry. Coming to the next, what is A? A is alkaptonuria. So first tell me what is the deficiency in alkaptonuria. It is homogentisic acid oxidase deficiency. Homogentisic acid oxidase deficiency is noted. So what do you see? If I ask you what is the main urine finding that you will have in this condition, all of you will say that there is something to do with black color. But before that, let me show you the biochemistry image that all of you are very fond of. And these are the things that you get in alkaptonuria. What was alkaptonuria? Homogentisic acid oxidase deficiency means homogentisic acid is not going to be metabolized. No one to break homogentisic acid. That homogentisic acid is elevating and is going and depositing in the tissues. What tissues is it going in? I can see if you look at the ear lobule over here, is it getting a little bit of a bluish blackish tinge? So first and foremost, it's going to go and deposit. What is ear? Ear is cartilage. Tip of the nose, ear. What are these? These are cartilage. So yes, this is going to go and deposit in the cartilage. Next, where does homogentisic acid go and deposit? I can see. I'll zoom in and I'll show you. Have a look at the nails of this person. These nails are becoming again a little bluish blackish. So yes, this is going and depositing in the nails. So that is the third thing. That's the second thing. And the third thing is that you see over here is the urine finding. And like all of you were saying, the urine is going to become black, but the urine will become black not, if you look at, there are two test tubes. The patient will give you this kind of a urine. Patient will come to you with a urine sample. That urine will be totally normal looking, but suddenly it is going to become black on standing. On standing, now this is a very funny story that I always share with students, because most of the books have written that the urine becomes black on standing. So there was a student in an offline class who once asked me that if the urine becomes black only on standing, this means only men must be having this problem and not women. So he actually understood that the urine becomes black when it is passed in a standing posture, not when it is passed in a sitting posture, not at all. When we say urine is turning black on standing, means standing in a test tube. This means on exposure to air. On exposure to air. So basically, when the patient will give you a urine sample, it's going to be nice and yellow, usual color. But if you leave it for 1 hour outside, the color will change into a black color. So that is what we mean by black on standing. And every time I teach this topic, it's been hundreds of times, but I always remember that student. Having said that, all in all, why is everything, whether it is black in the nails, whether it is black in the cartilage, or it's black in the urine, the black color is because of homogentisic acid. And this condition is also known as ochronosis. You must have read this in biochem. I'm trying to integrate this with as many subjects as possible, because you know that question will never come as a simple thing like alkaptonuria is autosomal recessive. No, they'll give you a clinical history and then you'll have to pick it up. So I'm trying to give you as many integrations as possible. Coming all the way back, having spoken about alkaptonuria, now let's go further and look at the other two S's, or the other two conditions that you have, and that is S and T. What is S and T? We have two hematological problems coming up our way: sickle cell anemia and thalassemia. Sickle cell anemia and thalassemia. You have already studied about it. Did I just tell you that sickle cell anemia is a point mutation? Thalassemia is also a point mutation in the previous segment, the introductory portion. So pasta is done. P and A, like I said, group them. P and A are enzyme problems. S and T are going to be hemat related problems. So talking about the fried, now as they say fried, it's the easiest to learn because this is going to be associated with Friedreich's ataxia. So when I write this, at least one aspect of the disease is clear. disorder. How will a clinical question come, guys? When you're talking about ataxia, means the patient is going to suffer from ataxia, so there is going to be some element of neurological involvement that is there, right? When we say neurological, brain, spinal cord, one more thing should come to your mind, and that is going to be the vertebral canal. So what is the other thing? These patients also have scoliosis. Which other organ can be affected? Cardiovascular abnormalities are seen. And yes, something that you study in orthopedics, pes cavis. So yes, this is how how have I learnt it for Friedreich's ataxia. So please remember, we have ataxia. Ataxia will immediately remind me of something to do with neurological. With neurological, I'll start thinking of the entire spinal cord. So there is scoliosis. Then I talk about the other orthopedic abnormality, that is pes cavis. And apart from that, cardiovascular disorder. That is Friedreich's ataxia. So at least one part of your mnemonic, that is pasta and fried. But what fried? Now we go on to the fried rice, that is fried chawal. So what is the chawal? That is exactly what we start off with next, and then we'll see how we can clinically integrate it, right? So first and foremost, we have C for cystic fibrosis. We have C for cystic fibrosis. We have C for hemophilia, or C, why am I still sticking on to the C? Because we say that it is hemophilia C. This means that there is obviously a condition called hemophilia A and B, which I will be coming on to later on. It's an XLR. But for the time being, I'm only focusing on hemophilia C. Okay. Having said that, there is also another condition called homocystinuria. Homocystinuria is also going to come under it. So how I have learnt it is, once I come down to C for cystic fibrosis, after that with the H also I have the C only. Hemophilia what? Hemophilia C. What is the other disease? Homocystinuria is going to come. Okay, coming on to the next, what is A? It's a very, very famous thing that you have to know. Alpha-1 antitrypsin deficiency. As you will go to systemic pathology, you will realize that this disease gets you a lot of questions. In fact, I see another A in this mnemonic, which I'll finish off. There is something called albinism. Albinism, everyone knows. There will be some hypopigmented lesions. A very famous previous year question is albinism. And they will also give you adrenal insufficiency, or they can either way say congenital adrenal hyperplasia. So there is something to do with adrenal gland involvement that is noted. There is congenital adrenal hyperplasia. CAH definitely gets you a lot of questions. I hope everyone remembers CAH was 21 alpha hydroxylase deficiency. They will give you that question of CAH, that is 21 alpha hydroxylase deficiency. What else, guys? Next we have W. With W, you will realize that there is a copper overload. There is a copper overload, and that is going to be Wilson's disease. Okay. When I've kept the copper overload, why don't I keep the iron overload also over here? So coming back, here you have hemochromatosis. Here you have the iron overload, that is hemochromatosis. So both the overloads are sorted for us. Iron overload, copper overload. Now let's talk about both the storage disorders. So what do we have? We have lysosomal storage disorders. So yes, lysosomal storage disorders are here. Even glycogen storage disorders are here. Okay, so finally your fried rice, chawal are ready. So pasta ready, fried rice ready. Cystic fibrosis, hemophilia C, homocystinuria, and hemochromatosis means iron overload. So that means now copper overload is also here, Wilson's disease. Enzyme deficiency, alpha-1 antitrypsin. We have albinism and congenital adrenal hyperplasia. I hope you remember the 21 alpha hydroxylase deficiency. Lysosomal and glycogen storage disorders. Almost coming to the end, because the last part of the mnemonic is big facts. Right now you might not understand big facts, but this will make a lot of sense when you go to the neoplasia chapter. Over there, life will become much simpler. What is big facts? Big facts refers to B for Bloom syndrome. Then take F and A together, that is Fanconi anemia. Fanconi anemia. And take the A and the X together, that is going to be ataxia, telangiectasia. Ataxia, telangiectasia. Finally, take the X separately, and that is xeroderma pigmentosum. Xeroderma pigmentosum. So repeating, what is big facts? B for big, something blooming, so Bloom syndrome. FA together for Fanconi anemia, AX together for ataxia telangiectasia, and X alone for XP, xeroderma pigmentosum. Where will you study this shortly? When you go to the neoplasia chapter, these are DNA repair defects. These are all known as DNA repair defects. So coming back, guys, as I started off this mnemonic, I told you there will be something called pasta fried rice, that is pasta chawal, and there will be big facts, and we have covered all of these. Now, which are the ones that you have to know in detail? Especially, you get a lot of questions on this lysosomal storage disorders. So I'll tell you the important ones. In the end, I'll give you a table, and we'll also try to learn some enzyme deficiencies from biochem, because we have to correlate now. So the first thing that you get over here is the most famous one, that is Tay-Sachs disease. What in biochemistry do you learn for Tay-Sachs disease? Everyone. T obviously for Tay-Sachs disease. A for, guys, what is the inheritance? Right now I'm studying autosomal recessive. What did I tell you? Autosomal recessive starts in young or old people. So it's autosomal recessive always has a young or a childhood onset. Okay, coming to the next, what is going to be? So if you've realized by now, the mnemonic for Tay-Sachs is Tay-Sachs only, right? So T for Tay-Sachs, A is going to be for autosomal recessive, Y is going to be for the young population. Okay, now we move on to the mnemonic, that is Sachs. So if you look very, very carefully, first question that will come to your mind is the enzyme deficiency. So yes, when we talk about the Sachs, you will realize that there is going to be hexosaminidase deficiency. There is hexosaminidase A deficiency. That is the main thing. And now I can tell you, they will ask you which is the population this will occur in. This will occur in the Ashkenazi Jews. This will occur in the Ashkenazi Jews. Now they will show you these three pictures. What are these three pictures? If they ask you in ophthalmology, ophthalmology shows you a spot. What is the spot? I see a spot over here. This is the very, very famous cherry red spot. And that's not it. What else do they ask you? They ask you cherry red spot is seen in which part of the eye? Cherry red spot is seen on a fundus examination at the macula of the eye. So S stands for a spot. Next, if you look at the neurons, can you see the neurons over here? It's not neuron is supposed to look at the cells around it. The cells around it are so tiny, and suddenly this one big neuron is looking like a big water balloon. Can I say there are ballooned neurons? And then you will ask me, why are they ballooned like this? They are balloon neurons because they contain fat. So these ballooned neurons, anything that contains fat is oil red O positive. That's a previous year question. Lastly, I see something related to neurons means I have some CNS abnormality present. So the C is also done. Now what am I left with? The last part, that is S is left, and this is a picture which is everyone's favorite. Which microscopy? Electron microscopy, the black and white picture. And what do I see? There is onion skinning, S for onion skinning. And having said that, the question that came in the paper was such a common sense question, but sometimes in the exam when you're very, very anxious, panicky, your common sense fades away. They asked you a very simple question. They gave you these three pictures. They said, this is a disease. All of you would have identified Tay-Sachs disease. They said this onion skinning is seen in which organelle? Ribosome, lysosome, mitochondria, nucleus. And everyone was like, okay, onion skinning we know, but where is onion skinning seen? So if you would have just put a little bit of common sense that it's a lysosomal storage disorder, so it is very, very obvious that the onion skinning will be seen of the lysosomes and not of any other organelle, of course. So sometimes, like I said, things are so evident, but we don't think of common things and we think of such rare things that we make errors, right? So now let's go ahead with the full form of Tay-Sachs disease. So T was for Tay-Sachs, A was for autosomal recessive. It is going to begin in young children. What is S? There is a spot. That is a cherry red spot that you see at the macula. A is going to tell you about the Jewish population, Ashkenazi Jews. C is going to tell you that there is CNS involvement. I can see these big, big neurons. H is going to tell you about the enzyme deficiency, that is hexosaminidase deficiency. And S is going to tell you about the onion skinning, everything about Tay-Sachs in this. Because now, if you keep the entire Tay-Sachs intact, means instead of Tay-Sachs, of course, but if you keep the same autosomal recessive, the same young person, the same cherry red spot, the same Jewish population, the same CNS population or the same CNS involvement, and the same onion skinning also, but now instead of the enzyme, because it's not Tay-Sachs disease, so it cannot be the H enzyme. What disease am I talking about? Now we are talking about the Niemann-Pick disease. Now we are going to be talking about the Niemann-Pick disease. And please remember, Niemann-Pick disease is a sphingomyelinase deficiency. Niemann-Pick disease is a sphingomyelinase deficiency. So yes, and what else? All of that is fine, but I can see something extra over here. I can again see a black and white photo, but this time the black and white photo is also showing me some stripes like a zebra. So remember, on electron microscopy, it tends to show you the zebra bodies. On electron microscopy, it tends to show you the zebra bodies. But tell me, does everyone have access to, electron microscopy? No, right? So then, how will it look like under the light microscope? Under the light microscope, it's very famous for showing you lots and lots of foamy cells. Once you see a foamy cell in the lysosomal storage disorder, then you suspect that, okay, I should do an electron microscope, and then I'll be seeing the zebra body. So please remember, there is going to be a lot of foaminess in Niemann-Pick disease. Very, very important question. Okay, having said that, let's move on to the next one. What is the Gaucher's or Gotch? I call it Gotch, ouch, because everyone knows that Gaucher's disease is to do with ouch. Means these are the patients who are going to present with bone pain. These are the patients very classically presenting with bone pain, and Gaucher's is G for G. G for G means there is a glucocerebrosidase deficiency. There is a G for G, that is a glucocerebrosidase deficiency. Now tell me guys, this is a very, very famous image that has come so many times in the paper, that whenever there is a glucocerebrosidase deficiency or there is a Gaucher's disease, what is this picture that you see? So you are going to visualize this, please remember, and zoom into it. Is it looking something as if you've crumpled a paper and there are lines on it? Yes. So this is famously known as the crumpled tissue paper appearance. The crumpled tissue paper appearance. And that is what you see in Gaucher's disease. So remember, firstly, G for Gaucher's, G for glucocerebrosidase. That's the deficiency. Okay, the Gaucher's is going to be ouch. So I say, okay, ouch means these patients are going to have bone pain. And now the recent question is, when we started saying glucocerebrosidase, a lot of people started asking, is there some CNS involvement? Is there some cerebrum CNS involvement? Yes. Remember, Gaucher's disease is of two types, that is type 1 and type 2. In type 1, there is no CNS involvement, but in type 2, CNS involvement is noted. This is the more severe type that we have. So, if you want to read it in a very complicated manner, there is always an option of reading complicated things. I can say this is non-neuropathic, this is neuropathic, other names, but why do you want to go into so much of unnecessary detailing and making your life tough? Let's keep it simple. The type 2, the bigger number is always going to be more severe, and that bigger number is severe because it shows you CNS involvement. So this is a question that came in one of the recent exams. There is a person who's come to you with bone pain, he's come to you with many organ enlargements like hepatosplenomegaly, and there is also neurological involvement. Many students felt that because neurological involvement is there, so it can't be Gaucher's. No, neurological involvement is there in type 2 Gaucher's, and this picture was given, that is crumpled tissue paper appearance. So having said that, if you have learnt about Gaucher's, please remember, the same crumpled cell, there is something known as a pseudo Gaucher cell also. So no points for guessing that if they just say the crumpled tissue paper appearance, Gaucher cell will be seen in Gaucher's disease, undoubtedly. But where do you see the pseudo Gaucher cell? That is seen in a leukemia called CML, but they look the same. both of them are going to look exactly the same, crumpled tissue paper appearance. How will I differentiate between them? There are lots of stains, but one stain which has come across as very promising is going to be the iron stain. So please remember, the iron stain is going to be positive in your Gaucher cell. The real crumpled tissue paper appearance, the real cell will have the real iron, whereas the pseudo Gaucher cell is not going to have the iron stain. Why am I saying iron stain? We are much more advanced. We know what the iron stain is. What is it, guys? You know it from the very first chapter, from the very first day of path. You all know it. Prussian blue stain, right? So if they ask you that you want to pick up a Gaucher cell, Prussian blue stain is going to be positive. Okay, so that is the story of Gaucher's, which means most of these disorders that I was talking about, we've somewhere finished. What all have we done? Let me just tick mark what all we've done. So let's quickly go ahead and revise all these enzyme deficiencies from biochemistry also. So over here, the first one, Tay-Sachs disease. We already know it was hexosaminidase deficiency, but I hope you all remember that in biochemistry, there's another way of learning it. And that is, instead of calling it Tay-Sachs, they call it 6, because 6 will always remind them that it is something to do with hexose. And Tay, the A alphabet is always written like this because it is alpha hexosaminidase deficiency. So for Tay-Sachs, alpha hexosaminidase. What is Niemann-Pick? Remember, pick. What are you trying to pick? You are trying to pick the spleen. These patients have splenomegaly. I am trying to pick the spleen. SP for spleen, SP for sphingomyelinase deficiency. Easy to learn, yes. Now we go to Gaucher's. For Gaucher's, where I told you the ouch, I told you how there was bone pain that was going to be there. Now we also know G for gluco. Now in the exam, going forward, you will see, I can see there are some places where gluco is written, some places where galacto is written. Now how is the confusion going to go? You will have to look at the name of the disease. When I'm talking about Gaucher's, I have the U in it. If I have the U in it, means I am going to be talking about glucocerebrosidase. Whereas the diseases in which I will have A's predominant, means there are no U's, there are only A's, there I am talking about galactosidase. So look at the next two diseases, Fabry's disease and Krabbe disease. This much I have understood, that Fabry's and Krabbe's don't have the U's, so they are not gluco problems, they are A-wala problems, they are galacto problems. And then one of them is alpha galactosidase, one of them is beta galactosidase. So now think logically, which of them has more B's? Krabbe has more B's. Krabbe disease has more B's, so that is the beta galactosidase. Fabry's has just one B, so that is going to be alpha galactosidase. Life is becoming easier. Moving forward, what is MLA? Metachromatic leukodystrophy shows you aryl sulfatase deficiency. Metachromatic leukodystrophy shows you aryl sulfatase deficiency, MLA. These were all the lysosomal storage disorders. I hope all of you remember these mucopolysaccharidosis also, Hurlers and Hunters. So yes, Hurlers and Hunters also show you, if I read them, there's an alpha L iduronidase deficiency, and then there's an iduronate 2 sulfatase deficiency. Simple. The 2 has to come in Hunt2. So Hunter's disease is going to show me the 2-wala deficiency, whereas the Hurler is going to show me the L-iduronidase deficiency. So you have to pick up alphabets from all of them and learn. Simple. Hurler, L-iduronidase, and Hunter is Hunt2, that is iduronate 2 sulfatase. Let's try our best that we can do a recap of all of these. So let's start, guys. When I talk about the Tay-Sachs disease, this is how we used to study in school. So today I'm going to make you study the way you study in school. That is, you put your hand on one side of the copy and you try to recall. So what is it for Tay-Sachs? So Tay and Sachs, 6 hexosaminidase. Which hexosaminidase? Alpha hexosaminidase. Niemann-Pick, pick the spleen. SP, sphingomyelinase deficiency. Gaucher's, as soon as I say Gaucher's has the U. Is it galactosidase or glucocerebrosidase? It is glucocerebrosidase. Then the ones which have A. Which are the ones which have A? Fabry's and Krabbe's. These are the galactosidase. Which is alpha and which is beta galactosidase? The one with lots of B's is beta galactosidase. The one with a single B is alpha galactosidase. Metachromatic leukodystrophy is MLA, so aryl sulfatase deficiency. And Hurlers and Hunters, which is going to have the iduronate 2 sulfatase. So 2 is going to be in Hunt2 and L-iduronidase is going to be with Hurlers. Having said that, go back to biochem, Try to revise this table. Things are going to be a lot easier now. Having said that, all lysosomal storage disorders are autosomal recessive, and now comes the twist in the story, except for Fabry and except for Hunter's, because now I'll be teaching you the next set of disorders which are X-linked recessive. Repeating once again, not Fabry's and not Hunter's. These are not there. So let us put a star here and let us put a star here. So remember, what do you do in hunting? You might have done hunting or you might have not. At least you've done archery. So hunting is like basically throwing or basically pulling an arrow or a gunshot on someone. So basically when you're doing any hunting or when you're doing anything to do with aiming, you have an aim. You have an aim and something of yours, either an arrow or a gunshot, is going to fly. So first and foremost, fly for Fabry. And hunting, you are doing hunting, so hunting for Hunters. And what are you hunting at? You are always hunting at a target. You've always seen those archery boards, they have an X and you have to aim at the X. Yes. So remember, when you are doing any hunting or any kind of archery and you are going to make your gun or you're going to make your arrow fly, so fly for Fabry's, H for Hunters. So Fabry's and Hunters are going to be the XLR. And that is exactly what I'll be starting with next. But before that, I hope our discussion of this remains very, very clear. We've finished all the autosomal recessive disorders, pasta, fried, chawal with big facts. I've told you all the details of biochem of lysosomal storage disorders. Having discussed all the autosomal recessive disorders, now let's move ahead with the XLR. So first let me tell you the concept of XLR, because now you will realize that in XLR you have somewhere entered into the sex-linked recessive disorders, the sex-related, sex chromosome-related disorders. So let us draw something out, guys. Have a look at this. First and foremost, if I say this, for example, is a normal male, a totally normal male. So you have X chromosome, you have Y chromosome. Here you have a female, and that female's small x has a problem. Small x, why? Because I'm dealing with recessive disorders. Small x has a problem. Can you tell me what are the possible combinations out here? So what is the first kid going to be? Capital X, capital X. No problem. This is a normal female that we have over here, not a concern. Then we have capital X and small x. Capital X and small x. This female is a problem, but is she going to show the disease? If the small recessive has a problem, disease will not show. Only when there's a problem in the capital X will a disease show. So having said that, this is not a diseased female. This is just going to be a carrier female. Let's take further. Capital X and Y, totally normal. This is a normal male. And the next one is small x and y. Small x and y is what? So now you say, what should I consider this as a male, small and capital? See, male has only one x. Keep it very simple. Male has only one x, whether that x is capital, whether that x is small, that is the only x it has and that is the only x that will function. Female had that option, what is capital, what is small, because she has two x's. Male has only one x, whatever that x will be, that x will show up. This means that the male is going to show you the disease. This is a diseased male. So please remember, the rule that you gathered out of this entire conversation is that in X-linked recessive disorders, I'm using a very complicated and a very diplomatic word called usually. Usually I'm seeing that female gender is going to show me the carrier state and male gender is going to show me the disease state. So why did I use this very diplomatic word called usually? Because you will say that can rarely female also have the disease? Yes, and I'll give you some examples which will make sense. Just think, for example, you have a case of Turner's syndrome. Do we all know the basic of what is Turner's syndrome? Turner's syndrome is 45x0. Turner's syndrome is 45x0 means this is that female which has only one X chromosome. Now, whether that X chromosome is dominant whether that X chromosome is something like a male state, there is only one X chromosome, whether it is a dominant X, whether it is a recessive X, whether it is a normal X, whether it is an abnormal X, whatever may be there in this X will show up. So can then she show up as a disease rather than a carrier? Can females show the disease? That's the question. Rather than being carriers, can females show the disease? Yes. If it's a Turner's and she has only one X chromosome, it can show the disease. Let's take up another situation. Right at the end of the chapter, you will come across a particular hypothesis where I have taught you what is Loyon's hypothesis. Loyon's hypothesis says that even if every female has two X chromosomes, we know that every female normally has two X chromosomes, but Loyon's hypothesis says that only one X chromosome will be doing all the work in the lifetime and one X chromosome will sleep off. So whenever you have double of something, one X chromosome, when you and your best friend are on duty together in internship, so one of you ends up playing some game on the phone and the other one is usually running around. So same way, when there are two X chromosomes, one will do all the work, the other one will sleep off. Now imagine the one that slept off, just as a hypothetical situation, this was the normal X and this was the disease wala X. Imagine the normal X ended up sleeping. This is what happened. The normal X has slept off. The female is left with only one active X and that X is the diseased wala X. Is she going to then land up with the disease? Yes. So maybe there's a problem in Loyon's hypothesis. That is when a female will have a disease. Or there is going to be Turner syndrome. That is when the disease will happen in females. Or the third situation, problem in mating, means in the previous one, I very nicely told you that male is totally fine. Male is totally fine. Female is the carrier. Means father is totally fine. The problem is only in the mother. But what if the problem is in the mother and the father both? Look at this person. This was a diseased male. When this diseased male ends up getting married further, what else will happen? So just imagine if a diseased male ever ends up getting married to a carrier female. What are the options that are going to happen? So remember, this is a diseased male. His X chromosome also has a problem. This is a carrier female. Her small X also has a problem. Will there be one possibility of a child getting X and X? Means both the X's will have a problem, and X means female. Is there a possibility that there is going to be a diseased female in this situation? Yes. So that is why I told you. Now you get back and learn it in a quick nutshell. Usual scenario is that the females will only be carrying the chota wala X. It is a carrier female. But the main disease will always happen in males. That is the usual scenario. But in case some problems happen, like the female is a Turner's female, or the female has a problem in Loyon's hypothesis, or instead of matching, an ideal match, they have ended up matching a diseased male with a carrier female, a very rare kind of marriage has happened, then also the female can land up with a disease. These three scenarios tell me, why did I use that diplomatic word usually? Because if they give you a question saying, in XLR, the females will always show you the carrier state and the males will always show you the disease, it cannot be always. Nothing is always in medicine. There are always exceptions. That is what is always. There are always exceptions present. Okay, having said that, now what are the diseases that are going to come under it? XLR is a very wise mnemonic. Why do I say it's wise? Because it's wise, A, B, C, D, E, F, G, H. Right? So let's start right away. What is wise? So the wise is going to tell you Wiskott-Aldrich syndrome. The wise will tell you Wiskott-Aldrich syndrome. When we talk about A and B, here I can tell you it is hemophilia A and B. It is hemophilia A and B. And guys, do you remember where did you study hemophilia C? Right now, in the previous segment, I told you hemophilia C was CAR, autosomal recessive. That is point number 1 that you have to notice. Very common place where the examiner will catch you. Hemophilia C is going to be CAR, that is autosomal recessive, whereas hemophilia A and B is XLR. Okay, moving on. What is with B alone? There is a disease that all of you studied way back in the inflammation chapter, and that is Bruton's hypogammaglobulinemia. Bruton's hypogammaglobulinemia, and now you will suddenly realize that everything that you were reading has started coming under one roof. Because did I tell you B for B? That time I made you mug up. B for B, that Bruton's hypogammaglobulinemia is more in boys, but now you understand why. Because XLR disorders, the disease only happens more commonly in boys. In XLR disorder, the disease is only more commonly in boys. So a lot of things are making sense now. Okay, so the B is done. What is with C? This was another disorder that, guys, you studied in the second chapter, chronic granulomatous disease. Do you remember what was chronic granulomatous disease? It was a phagocytosis, NADPH oxidase deficiency. Another C, color blindness. Which color blindness? Red-green color blindness. Red-green color blindness. And because I'm talking about color, blindness, eyes, I will also write ocular albinism. So albinism, because it's hypopigmentation, something to do with color. So with color blindness, I have written ocular albinism, and here you have to make table number 2. If they would have just asked you albinism, albinism means to do with the skin hypopigmentation. Albinism I had taught you in the previous segment. Albinism was A for A, it was autosomal recessive. But if they ask you ocular albinism, it will be XLR. It is going to be X and L and R. I've taken the first, center and last. So ocular albinism is XLR and only albinism is A for A. Okay, so A, B, C, and now we come on to D. What is D? DMD, BMD. What is DMD, BMD? It is Duchenne muscular dystrophy, and it is going to be Becker's muscular dystrophy. So Duchenne's muscular dystrophy and Becker's muscular dystrophy. One of the recent exam questions was, what is the gene? So dystrophin, the common sense should come over here. That is, there is a dystrophin gene which is going to be problematic, and then they ended up asking you, dystrophin gene is present on which chromosome? Guys, use your common sense. Obviously, it has to be on chromosome X. That is why it is a X-linked recessive disorder. So dystrophy word came, muscular dystrophy, because of dystrophin gene. So A, B, C, D. Now we move on to the next part. E, I could not make much out of it. So we said Lesch-Nyhan syndrome. That is how we've learned it. We have learned it as Lesch-Nyhan syndrome. Okay, guys, if I have to give you a question of Lesch-Nyhan syndrome, I'm not going to ask you as a one-liner that what is Lesch-Nyhan syndrome. I'm going to give you all a picture. Have a look at this image. What is this? Why is this considered as a picture of Lesch-Nyhan syndrome? Because it shows you a person who's biting his nails and biting his skin. Means there is something known as self-mutilation that I can see in this picture. And guys, do you remember what is Lesch-Nyhan syndrome a deficiency of? It is HGPRT deficiency. I'm giving you a lot of pearls of integration with biochem because this is exactly how the questions will come. So please remember, they will show you this picture. They will say there's a person who's eating his skin. Skin eating is definitely nail eating, many of us do, but skin eating is something that is a sign of self-mutilation, and that is what you see in Lesch-Nyhan syndrome. What is the deficiency? It is the very famous HGPRT deficiency. So coming all the way back, we are done with Y's A, B, C, D. Now we are also done with the E. Now we come to F, G and H. But I think some of them I can fill in the blanks. Remember I told you all the lysosomal storage disorders were autosomal recessive, but if you have an arrow flying towards the hunter with an arrow flying towards the target, remember that story? The flying means Fabry's disease and the hunter means Hunter's disease, right? These two I will put under XLR. Not only that, we also have something called Fragile X syndrome and disease, which I'll be teaching you in exactly some time in the next segment of non-Mendelian disorders also. But please remember, for the time being, there should not be any confusion. Many students come back to me saying Fragile X syndrome, we have read it is XLR. Some students say we have read it is XLD. It's not your fault, because see, Robbins and Harrison, the two Bibles, the two godly books of this entire medical profession, Robbins and Harrison mention XLR. Then there's a very famous book called Davidson that mentions XLD. So I can never say that any Bible is wrong. Both of them are right. So basically, Fragile X word only tells me that any X-linked inheritance is possible. But since my loyalty is more towards Robbins and Harrison, I will say select XLR, and that is why I have given it to you in this mnemonic. If any books mention XLD, it's not wrong, okay? Having said that, what is the last one? G for a very famous anemia called G6PD deficiency anemia, and that mnemonic is done. So we have a WISE A, B, C, D, E, F, G, H. A quick revision. WISE is going to stand for something very wise, that is Wiskott-Aldrich syndrome. AB for hemophilia AB, not hemophilia C, that is AR. B for Bruton hypogammaglobulinemia. C for CGD. C for all color blindness and all the eye related things. Ocular albinism is XLR, but albinism is AR. Okay. Next, D for DMD, BMD, Duchenne's muscular and Becker's muscular dystrophy. Dystrophy obviously means dystrophin gene is the problem. E for Leishman syndrome. Remember that baby who, or the kid or the human who will be eating his own skin, self-mutilation. F for Fabry's, H for Hunter's, F also for Fragile X, and G for G6PD deficiency. Out of these, if a biochem question had to come, they might give you Fabry's syndrome urine findings. What do you see, guys, in Fabry's syndrome? So please remember of Fabry's disease for that matter. In Fabry's disease, we see the very famous Maltese cross appearance. Can you see this kind of a cross? That is what you see, and this is actually something to do with lipid coming out into the urine. This is because of lipid coming out into the urine. So is there some other disease which you guys know very, very famous in kidney where lipid comes out into the urine? That very, very famous disease is nephrotic syndrome. So basically in nephrotic syndrome also fat comes out into the urine. So this means if you see the lipid or if you see the urine of a nephrotic syndrome person, you will see this Maltese cross appearance. This is the Maltese cross that you have with regard to pathology, means anything with lipid coming out into the urine, like Fabry's disease, like nephrotic syndrome. But if I ask you, where do you see the Maltese cross appearance in microbiology? You can see something like a cross. Which organism? Very, very famous, Babesia. Babesia shows you the Maltese cross pattern. So like I said, the good news of reading two lab subjects together is that you can have all the lists as a combination list. So if you are asked about something to do with a Fabry's or something to do with nephrotic, they will give you this microscopic picture. And if they tell you something to do with microbiology, means Babesia organism, Babesia is something which will show you this kind of a Maltese cross. Yes. Having said that, all your XLRs are done. We move on to XLD. Before I tell you the mnemonic, let me tell you the concept. So I'll tell you a very, very easy way of picking up XLD. When they talk about XLD, everything is going to be D, 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 D. Means what? In XLD disorder, the dad is going to give the disease only to the daughters. Dad will give the disease only to the daughters, and I'll prove that to you. And it's, even before I get into it, just put a little bit of common sense. Every dad or every male is X and Y. Right? Whenever this person becomes a dad, Y chromosome will go to whom? Y chromosome will go to all the sons, and X chromosome will go to whom? X chromosome will go to all the daughters. So just put a common sense now that if a dad's X chromosome has a problem, all the daughters will end up having a problem. And if a dad's Y chromosome has a problem, all the sons will end up having a problem. It's as simple as that. So having explained that, let's draw it out. For example, this is a dad with a problem in the X chromosome, and this is a normal female. Let's start making combinations. And I've kept everything capital because I'm dealing with the dominant disorder. So capital X, and this X has a problem. Is this a female or a daughter who is diseased? So DD, there is a daughter disease happening over here. Let's take the next combination. Another XX, another daughter coming up with the disease. Same situation, another DD, daughter disease. Let's look at the sons. X and Y, they don't have a problem. X and Y, they don't have a problem. Sons are totally normal. So I gather in XLD, it is the dad who is going to give the disease to the daughters, D, 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 D. And that is what you have to know. But you always will ask me that when these daughters will later on become mothers, what is going to happen? Earlier you said when the dad has the disease, the daughters have the disease. But when this daughter will become a mother, please remember the daughter will give the disease to 50% of the offsprings. So just as an example, if this female further becomes a mother and she has 4 children, 2 of them are going to have the disease, 50% chance. So there's a very, very famous rule for this XLD which I have written. And what is that rule? That rule is DDD. Dad will give the disease to the daughters, and daughters will then give the disease to 50% of the offsprings or children. What is the mnemonic? It's one of the shortest and one of my favorite mnemonics, easiest to learn, and that is Ravi. What is Ravi going to tell me? R is going to be a neurological problem called Rett syndrome. R is going to be Rett syndrome. A is a very famous Alport syndrome. V is the famous exam question, vitamin D resistant rickets. Vitamin D resistant rickets, also known as X-linked hypophosphatemic. So there's going to be hypophosphatemia that you will see over here. And I will show you some questions also shortly. Hypophosphatemia and X-linked vitamin D resistant rickets. And I for incontinentia pigmenti. I for incontinentia pigmenti. So now comes the real problem. Go way back to the first mnemonic we did. He has a very dominant and powerful father. Dominant. What was this a mnemonic of? Autosomal dominant. This had an I called intermittent porphyria. Now in the exam, all these I's and A's will get confused. So that was intermittent porphyria. This is incontinentia pigmenti. How will I learn? See guys, what is Ravi? Ravi is what? Ravi is the Hindi of what? Ravi is the Hindi of sun. Ravi is the Hindi of the sun. So when I'm talking about sun, moon, land, water, continents, I will keep all of them together. When I'm talking about sun, moon, land, water, continents, so incontinentia pigmenti should come with this sun mnemonic, that is Ravi. And the other I, intermittent porphyria, goes in autosomal dominant, just a small way of learning it, otherwise life becomes tough. The next controversy that comes in the paper is the controversy of Alport syndrome. Now, when I talk about Alport syndrome, you will realize that all the inheritances are known in it. Means it can be autosomal dominant, it can be autosomal recessive, it can be XLR, it can be XLD. All of them are known. But as per Harrison's, the most common inheritance known for Alport syndrome is XLD, and that is why I have got it to you over here. But like I'm telling you, remember Alport, if they have an option of all of the above, yes, Alport can show you all of the above, right? Okay, that was about XLD. Coming to the last one, and that is going to be Y-linked, the easiest, because Y-linked means now there are only male members affected. All the male members of the family chart are going to have this disorder. So tell me, dad to all what? Dad will give the disease to all the daughters or all the sons? Common sense. Y chromosome will only go to the sons, right? So dad will give the disease to all the sons. And that is known as Y-linked. For Y, I told you, you can learn the word androgen, males, androgen, so holandric inheritance. And the only example that you have to learn over here is hypertrichosis. When I say hypertrichosis, basically means lots of hair. Hairy ears. Hairy ears is something that will come here. So repeating once again, Y-linked or holandric, lots of hair. Men are more hairy. So that is how you can learn this. With which all your Mendelian disorders are done. But there's one disease which I've not spoken about anywhere. And that disease is the very famous Ehlers-Danlos syndrome. Why did I not speak about it anywhere? Because please remember, when we say Ehlers-Danlos syndrome, it can be autosomal dominant, it can be autosomal recessive, it can be XLR, all these are possible. So I could not have put it under one category. So first and foremost, what is Ehlers-Danlos syndrome? Then I'll be showing you a particular table showing you all the EDS types. Remember, Ehlers-Danlos syndrome is a collagen defect. Ehlers-Danlos syndrome is a collagen defect, and collagen is present where all? Collagen is present so many parts. It's present in the skin. So if there's a collagen problem, the skin is going to be very, very thin. The skin is going to be very, very thin. You know how thin does it become? They start describing it as cigarette paper skin. Cigarette paper, the rolling paper, which I hope you guys are not consuming, but that rolling paper of cigarette, that cigarette paper, that is how thin the skin becomes. Where else is the collagen present? Collagen is present in blood vessels. So obviously there is going to be blood vessel breakdown. There's going to be blood vessel breakdown. Patients are going to come to you with a lot of bleeding problems. Same way, collagen is also to do with joints. This means the joints are gone. This patient has hypermobile joints. The patient is going to have, the joint can be moved in any direction, any kind of 360 direction it can be moved around in. So just remember, Ehlers-Danlos syndrome is a collagen defect. Where all the collagen is present, it's going to be a problem. And now I'll tell you a very, very tough table. And I know all of you have seen that table earlier in medicine, in biochem, in so many other places, and it's undoubtedly a tough one. But we'll try to simplify it in whatever way we can. So first I can see there is 1, 2, now even actually more than 7, now even 8 is known, but we limit ourselves somewhere. 1 to 7 is known. So remember, 1 and 2 are the classical ones. When I say classical ones, they are the classical collagen 5. If someone asks you what is that one most common defect that you see, that is collagen 5 defect is seen. So the classical ones which will show you classical symptoms, they are going to be collagen 5 problem. Okay, the third one, how do you say 3? 3 means, how I rhyme it? 3 free. Why did I say 3 free? Because when I say 3 and I rhyme it with free, who is going to become free? The joints are going to become free. Hypermobile joints. The joints can be moved in any direction. So 3 free joints. That is how we have learnt it. There are free joints that will be noted. Okay. Coming on to 4. With 4, I have learnt flood. In 4, there's going to be a flood of blood. Remember that. So that is why I called it the vascular type. 4 is going to show me a flood of blood. Okay. So it's the vascular type. And vascular, what is the collagen? This I have taught you way back in your inflammation chapter. Guys, what is the type of collagen that you have in blood vessels? We have collagen 3. So what is the problem going to be there in the vascular type? It is type 3 collagen. What were the first 2? The first 2 were collagen 5. For 3, we don't know the defect till date, so I don't want to comment on that. For 4, the vascular type, that is collagen 3. So I think till here life is a little simpler. Let's try and recall this once again, guys. When I say 1 and 2, these are the classical varieties. These are classical varieties. So they are going to show me the classical defects, that is collagen 5. When I say 3, 3 is reminding me of free. The joints are going to be free, so hypermobile. I don't know the antigen. When I say 4, 4 is reminding me of 4 flood. So remember, 4 is going to show me a flood of blood. This means that is going to be a vascular type. Now comes 5. 5 is the same as 2. 5 is the same as 2, only the inheritance is there. And this I've noticed in a lot of other places also. Have you noticed in immunity? Hypersensitivity. 2 and 5 hypersensitivities are the same with minor differences here also. 2 and 5 numbers are the same. The only difference is that whatever I taught you up till now was autosomal dominant. 1, 2, 3, 4, the main ones, the dominant ones. 5 is different because it is XLR. It becomes X-linked. So otherwise everything is the same. Now let's come to 6. The 6 will remind you of S for S. S, S and S means there is scoliosis. In type 6, there is kyphoscoliosis and there is lysyl hydroxylase defect. So remember, type 6, scoliosis, lysyl hydroxylase defect. This becomes different. This is autosomal recessive. Now look at 7. 7 has ABC types. I can see some joint problem. I can see some skin problem. If you can learn the defects, very good, but these are the least asked. So can this be somewhere ignored? I feel yes. But yeah, at least you should know 7, 1. But out of that, please remember 7A and B are the main chunk of it, the main bulk of it, that is the dominant one. And 7C, which is going to have dermatosparaxis, that is the skin problem, that is autosomal recessive. So again, repeating once again so that we can have a rapid revision and finish this topic off altogether. The first 2, which are the classical ones will show me the classical defect, that is collagen 5. The third one, which is going to be the 3, and 3 will remind me of free. So the joints are going to be free. It is hypermobile type. I don't know the defect. The 4 one, that is going to be the classical. The 4 will show me a flood of blood. So that is going to show me lots of bleeding manifestations inheritance, that is vascular type. Blood vessel has collagen 3, so that is a defect in 3. The fifth one is nothing but a variation of the second one. So that tells me all the ones up till here were autosomal dominant, but this fifth one is just X-linked recessive or X-linked inheritance. Now coming to 6. 6 is going to remind me of scoliosis and lysyl hydroxylase, so that is going to be 6. 7 is going to be A and B. The chunk over here is autosomal dominant. The minor one in the periphery, C wala, is autosomal recessive. The chunk is going to be the arthrochalasia type and the C is going to be dermatosparaxis type. Having said that, I realize that Ehlers-Danlos syndrome is a multi-inheritance, inheritance pattern, so I cannot fit it in any mnemonic. I hope all of you have learned the mnemonics, all 5 of them. Time for some questions. Quick one-liners and some questions to do with clinical scenarios. Where would you see sickle cell anemia? If you all remember your mnemonic, there was some very famous food-related pasta, fried chawal mnemonic. What was sickle cell anemia and thalassemia? Means they were autosomal recessive. So that is what you pick up over here. Coming to the next one, Duchenne muscular dystrophy. Where did you study DMD and BMD? There was a wise ABCDEFGH mnemonic. Who was wise? XLR was wise. ABCD. In that ABCD, you had DMD, BMD. Coming to the next question, what is hemophilia C? This is what you have to read with a lot of caution, guys. Hemophilia A and B was XLR, but hemophilia C was a CAR. Hemophilia C was autosomal recessive, that pasta, fried chawals. Remember CH, hemophilia C. Another question, hypertrichosis. This is my favorite. Lots of hair. Men have a lot of hair. So men inheritance, Y-linked, but Y is not given in the options. What will you select? Y-linked is also known as Hollandric inheritance. Coming on to the next one, little lengthy question. Here you have a 22-year-old man. Arm span greater than height. So arm span, fingers, arms, everything is very tall. There is subluxated lens, dislocation of lens. There is a dilation and flattening of aortic bulb. A lot of features are sounding very, very similar to Marfan syndrome or Marfan's disease. So dislocation of lens is there. The aorta is involved. I can see that there is arachidactyly and long fingers. I know Marfan is a problem in fibrillin 1. Which chromosome? It was related to chromosome 15. Coming on to the next question. Very famous, and if you ever feel that the examiner is going to get sick of this, no. Imagine this even came in the November INI CET 2022. So till the very latest exam, this question has come. So remember, crumpled tissue paper appearance that you see over here is Gaucher's disease. I hope you remember what deficiency, galactosidase or glucocerebrosidase. The U is coming. So I will be using glucocerebrosidase deficiency. Moving on to the next question. Now, this is something which students have always asked me that I should discuss. But before I start with this, if you've read hematology, this question is going to be a cakewalk. If you've not read hematology, I will first have to tell you a hemat concept. Just listen to me for 1 second. Have you all heard of something called thalassemia minor? I just want to tell you that the diagnosis of thalassemia minor is made when the person is having HbA2 levels of more than 3.5. This hemat concept you need to know before solving this question. Repeat with me. What is the HbA2 level that a person should have for you to label him as thalassemia minor? 3.5. Let's start reading this question. Remember, there's a 32-year-old pregnant female who has come to the antenatal clinic visit, and after she has conceived, first visit everyone makes. On blood reports, Menzer index is 11. So what is Menzer index? So first and foremost, another concept that I want to tell you over here, Menzer index is, take the first alphabet, take the last alphabet, it is MCV upon red blood cells. And if this index comes out to be more than 13, I think of iron deficiency anemia. If this index comes out to be less than 13, I think of thalassemia. And how have I learnt it? Instead of calling it thalassemia, we call it thalassemia, because that will tell me less than 13. If the Menzer index is less than 13, I will think of thalassemia. What is the Menzer index over here? Menzer index is 11, means the Menzer index is less than 13. 13, I have started thinking of thalassemia. So this means this pregnant female maybe has thalassemia. How will I confirm? If a Menzer index is less than 13, I will start thinking of thalassemia. How will I confirm it? I will confirm it by doing HbA2 levels. What are our HbA2 levels, guys? Are they more than 3.5? Yes. Is she a known case of thalassemia? I have understood that the mother over here has thalassemia. What am I worried? What is her child going to have? So for that, I need to know what did her husband have. I call her husband. Her husband is also made to undergo the same test. Husband is also said to have an HbA2 of 4%. Means the husband also have thalassemia. Now imagine both the husband and the wife have thalassemia. What have they asked you? They have asked you what is the probability that the child will be suffering from the disease. So what disease are the husband and wife carrying? They are carrying thalassemia minor. They want to find out, will the child have thalassemia major? Because if the child has thalassemia major, it is a non-curable disease. It's going to be a big time problem. So for that, you will have to tell me, guys, thalassemia was coming under which disorders? Thalassemia was coming under pasta, fried chawal, so autosomal recessive disorder. So what are we going to do now? We will draw these two, husband and wife, and I am saying that they have an autosomal recessive disorder. Recessive disorder means thalassemia minor. The small things have a problem. Recessive things have a problem. What is the probability that their child will have thalassemia major? Tell me. Capital A child born, not a problem. Capital A, small a child born, that child will also be thalassemia minor. I am not interested in minor. They have asked me which child will have thalassemia major. Okay, next, capital A and small a child form. This is also a thalassemia minor. But which is the child which is going to show me small a means thalassemia major? What percentage? Count for me. 1 out of the 4 kids. So total there were 4 kids, and who has had thal major? Only 1 out of the 4 kids is going to have thal major, basically 25% if I do my mathematics. Coming back, here I have how many kids will be suffering from thal major, and I will give my clear-cut answer as 25%. If I would have changed the question, the same question, and I say how many of the kids will again be born with thalassemia minor, what would your answer be? How many kids will be born with thalassemia minor? 2 out of 4, 50%. How many kids will not have any problem at all, neither minor, not major? 1 out of 4, 25%. So the same question can come, but yeah, this is a question which is a real-time integration. I call this as a super integration because how it has picked up from your Menzer index of hemat, gone into your hemoglobin analysis of hemat, come back to the genetics, and then made you do mathematics also. So it's a super duper mega integration that happens. If you still had any concern in understanding this, means you will get back to this question once you read hematology. Because when your basics of hemat will be clear, then this question will make a lot more sense. Having said that, let's quickly go ahead and do one more question over here, guys. A father has an X-linked dominant disorder. How many percentage of daughters will be affected with the disease? I don't think you need to do any 2x2 charting. If I have an X-linked dominant disorder, the dad is going to give the disease to all the daughters. That is what I had studied. Dad will give the disease to each and every daughter. DDD, XLD, dad, disease, all daughters. So all 100% daughters are going to get this disease. I hope it's okay with everyone, because now we'll move on to a lengthy clinical question which you guys will also find in your Q bank. Here you have a 12-year-old boy who's brought to his by his parents in the medical outpatient department. There is bony aches and pains. They also have noticed there is bending of his lower extremity. So a lot of bone related symptoms are there. There's a family history was significant for complaints in his mother. So you've got a pedigree. I'll be teaching you pedigree in the next section, but here you have a kid and they have said this is probably the kid, and they are saying the kid had something similar that happened in his mother also. Okay, the vitals are heart rate 90, blood pressure 120/80, respiratory 14, temperature 98.6. Some time-based things are always mentioned. Physical examination obviously shows that there is involvement of bowing and there is always presence of enlargement. So all these rickettsial changes are seen. Investigations show what? They show hypophosphatemia. Did I tell you vitamin D resistant rickets is also called X-linked hypophosphatemic rickets? Hypophosphatemia is saying whatever is your possible diagnosis, what is the mode of inheritance? Now, even if you don't look at this pedigree chart, I know that if I'm talking about vitamin D resistant rickets or hypophosphatemic rickets, this is belonging to the Ravi mnemonic. Ravi mnemonic means XLD. I have a classical XLD that I have to think of. But even if I would have gone on to this pedigree, what did you notice? Here you have a boy. Here you have a boy, or you can say a dad, and dad has given the disease to all whom? Dad has given the disease to all the daughter. What is that inheritance? Where dad gives the disease to all the daughters, DDD, that is also XLD. So even if you would have solved it via the pedigree, or you would have solved it via the clinical history given, your answer would have come. So it's a vitamin D resistant hypophosphatemic case. This is XLD. With which, guys, we also wrap up our entire discussion of Mendelian disorders. The lengthiest part of this chapter is done. Now we will move forward and study about the non-Mendelian and the chromosomal disorders.